So, good evening, everyone. My name is Ghedaa Armosh. I'm a third-year medical student, and today joined with.
Guys, I'm Reem Ahmed. I'm also a third-year medical student.
And today, both of us will be hosting this neuro OSPE session. It's going to be a little bit of a long one because it's going to be including not only OSPE-related or lab-related content, but also because neuro is such an integrated block, it's going to also include some stuff from clinical and in general, yeah. So strap in, inshallah. It's also going to be interactive. However, we would prefer if you guys type in your answers in the chat instead of hitting your mics, just to give everyone the chance to participate equally. So yeah, without further ado, we'll start. This session will be divided into 3 sections: anatomy and histology, physiology, and microbiology. At the end of the anatomy and histology part, we're going to be having questions. But throughout the entire session, we would like for you guys to be as interactive as possible because we're going to be asking questions, and yeah, and a lot of it would be also a review from any other sections. Now, starting with the skull. The skull, we're going to start with the anatomy of it. It's going to include the skull anatomy and the foramina and the meninges and dural butterfly. Starting with the foramina and the anatomy of the skull. We're going to be looking at the beginning at the skull from different views, anteriorly, laterally, and posteriorly. The one main thing that we need to take away from this slide is, first of all, how the slides look in different angles, and also the main bones that are contributing to the formation of the skull. You can see that the frontal bone, the parietal bone, the temporal bone, the sphenoid bone are recurrent bones that mainly make up the skull infrastructure. You can see that anteriorly, laterally, sphenoid, parietal, temporal, occipital, and the frontal, as well as posteriorly. Now, the skull also is made up of 2 parts: the neurocranium and the viscerocranium. The neurocranium is the one we're going to be concerned with in the neuro block. Viscerocranium, you guys will take it in the next block, inshallah. Now, as you can see in this diagram, the neurocranium, highlighted here in purple, is mainly contains the bone that we discussed in the previous slide. So the parietal bone, the sphenoid bone, the temporal bone, so on and so forth. Another way to classify the skull, or you need to break the skull into parts, is the fact that it has 2. If you break it open in the middle transversely, it can form 2 sections. Does anyone know what the name of this? What is a name for this structure right here? Okay. So it's called the skull cap, or the claviera, and the base of the skull is called the cranial base, and this is where the majority of the rest of the skull section will tackle. Now, the claviera, if you look at it from the top, you're going to see 3 main bones: the frontal bone, the parietal bone, and the occipital bone. If you look at it from underneath, you're going to see the same 3 bones as well. The cranial base, which is, as I said, the main thing that we're going to be concerned with in this crash course or in this OSPE review, you're going to see, if you look at this from down, from upwards, you're going to see that the frontal bone, the ethmoid bone, sphenoid bone, temporal bone, parietal, and occipital are the main ones that you're going to be seeing in the cranial base. And these are the main ones that we're going to be concerned with, as I said. If you look at it from posteriorly, this is the view that you're going to get. However, we're not going to be talking about it. General overview, again, because from now on, it's all going to be interactive and there's no more talking from my side, basically. The last classification that we're going to be concerned with is, for the floor of the cranial cavity, is the classification in terms of the view. You know what I mean? So from the anterior view, or if you look at it from above, you're going to see that it's divided into three fossas: the anterior fossa, the middle fossa, and the posterior fossa. And these bones, all of them, have a place within these fossas. Okay, and we're gonna see how that plays out in the rest of the slides. Any more questions before we start? Okay, I'm gonna assume and everything is okay, all clear. Starting with the first fossa, or the anterior fossa, we have one thing that, or one structure that is mainly found in this one structure. Two bones that are found in this in the anterior fossa: the frontal bone and the ethmoid bone. We're gonna start with the frontal bone. The frontal bone has one structure, the one main structure that we're gonna need to identify. Does anyone know? And it's highlighted here by these two stars. Does anyone know what the name of this structure is? Okay. Okay. It's the orbital plate. Because okay, I understand. Because of the fact that it's highlighted by these two stars and it's called the orbital plate, you can understand that it can be found above the eye, so in this area right here. And it forms the upper portion, or the upper border of the orbit. Yeah, as I said, it's this portion right here. That's it for the frontal bone. The ethmoid bone has two main structures. I'm gonna give you guys a hint. One of them is a fossa. Does anyone know the name of the fossa at least? Okay. It's called the cribriform blade and the crista galli. The crista galli is a perpendicular structure found in the middle of the ethmoid bone, and it forms this separation between the right and left cribriform plates. And this is the entire view, how it looks like from a sagittal view. The cribriform plate is found on the sides, as you can see here, from this side and this side. And the main thing that you guys are going to be concerned with when it comes to the cribriform plate is the fact that it allows for one cranial nerve to pass through it. What is the cranial nerve? Okay, cranial nerve 1, which is the olfactory nerve. Exactly. It allows for the olfactory nerves to pass through and to interact with the olfactory bulb found inferiorly. Now, moving on to the last structure, found in the anterior fossa. It's related to the sphenoid bone, and because it's going to be a little hard for you guys to identify it, I'm going to just say what it is. It's going to be the lesser wing of the sphenoid bone. The lesser wing of the sphenoid bone can be seen right here. It's this structure, and while it might seem a little not that important, however, it's very important when it comes to the folding of the dura, which is going to be something that we're going to talk about in a later section. However, just keep that in mind. It's very important when it comes to the folding of the dura. Moving on to the middle fossa, and again with the sphenoid bone, because the previous one was the lesser wing, what would this be? The structure be? Okay, the greater wing of the sphenoid bone. The greater wing of the sphenoid bone gives or has a very big, or takes up a very big surface area of the base of the skull. Because of the fact that it takes up a big surface area, and as you can see, it's also associated with a lot of the foramina that are found in the base of the skull. These foramina are very important in the sense that it allows for various structures to go in and out of the skull. These structures can be either nerves, specifically cranial nerves, veins, arteries, so on and so forth. And they are very, very important when it comes to us identifying what structure passes through each fossa and so on and so forth. So this is an important point, guys. Okay. Another thing that we need to identify in the sphenoid bone is this little structure right here denoted by the star. Does anyone know? And you guys took this before in another block. So What is it called? The solitary chicane. What is the structure associated with the solitary chicane? The pituitary gland, exactly. The solitary chicane is a low depression in the bone found in the sphenoid bone, and it allows for the pituitary. It allows for the perfect cushioned space for the pituitary gland to sit through, to sit in. And yeah, the next thing that we're going to highlight in the middle fossa in regard to the sphenoid bone is the anterior and posterior clinoid processes. These processes are not that important for you guys. However, I'm just including them for the sake of completion. The anterior clinoid process is found right here, and the posterior clinoid process is found right here. The anterior clinoid process, as you guys can probably tell, if you've been following, it's the distal part of the lesser wing of the sphenoid bone. So it just acts as attachment processes. Now moving on to the sphenoid phenomena. As I mentioned before, these are made up by the greater wing of the sphenoid bone. Okay. Now, this is a part where you guys are gonna have to be interactive. Okay. The optic canal is the first sphenoid phenomena that we're gonna discuss. What comes out of this optic canal? Two structures. Or passes through it. Okay, optic nerve and the ophthalmic artery. Excellent, inshallah. Okay, and then we're gonna go over to the second one. And the way I'm going about this, and the way I think you guys should go about this as well, is we're gonna go over them in order. So from top to bottom. And this way you guys can sort of understand the flow of structures as they go through each canal and each fossa. So the optic canal, as we said, the ophthalmic artery and optic nerve, it just makes sense because it's the optic canal. It's called the optic canal. The superior orbital fissure is the second structure that we're going to be discussing. And it has a couple of structures. Oops. A couple of structures. Can anyone list them out? Or at least some of them? MashaAllah. Okay. You guys are on fire, mashallah. Okay. So the superior orbital fissure allows for the passage of the oculomotor nerve, the trochlear nerve, abducent, ophthalmic, and the superior ophthalmic vein. Okay. So that's it for these ones. Then we're gonna go over foramen rotundum. What are the structures that pass through foramen rotundum? Exactly. MashaAllah. The maxillary nerve, which is a division of the trigeminal nerve, the second division. Then foramen ovale. So, okay. It has a bunch of structures as well. Can anyone listen out? And okay. The rest of the structures that are found in, or yani, that come out of foramen ovale are not that important clinically. So I understand why you guys wouldn't yani, know them out of the top of your head. However, they do come up. So it would be good for you guys to know them, especially in later blocks. So the mandibular nerve, which is the third division of the trigeminal, the lesser petrosal nerve, the accessory meningeal artery, and the emissory vein. Yeah. Moving on, we have the foramen spinosum. You guys should know this. It's very clinically important. Okay. Foramen spinosum, the structure, exactly, the middle meningeal artery. It's a very clinically important artery that is that passes through the foramen spinosum. Then the foramen lacerum has the crater petrosal nerve. I didn't expect you guys to know this. It's not a very important nerve, however, it's good to know. And lastly, the carotid canal. It's in the name. It gives out the internal carotid artery. Okay. Yeah, exactly. Okay. Moving on to the temporal bone. The temporal bone is a little bit of a forgotten bone because especially in neuro, you guys don't take much about it. However, it would be good for you guys to know because it's in your objectives. The squamous part in the middle cranial fossa, two structures are found related to the temporal bone, the squamous part and the anterior surface of the petrous. Okay. You guys are gonna need to be able to at least identify how they look. Okay. This is how the temporal bone looks like from the side and then from the inside. As long as you're able to identify it, the temporal bone, I mean, Generally, you guys will be good, especially in neuro. However, يعني, in HNS, it's more important. Anyways, as you can see by this picture, generally the temporal bone has four main parts: the squamous part, the petrous part, the mastoid part, and the tympanic part. The ones that we're concerned with in neuro is the squamous part, which is the top part, the one that can be found right here, and then the petrous part, which is this part, the one that can be found right here. Okay, so as long as you're able to identify that, you're good. Okay, the parietal bone in neuro, again, is not that important or not that relevant for you guys. As long as you're able to identify this is the parietal bone on the sides, that's more than enough. Okay. Now that we're done with the middle fossa, it was a big chunk, we're gonna start with the posterior fossa, starting with a bone that we already discussed, the temporal bone. However, now we're going to be discussing or talking about the posterior surface of the petrous part. So the petrous part is this part that we talked about 2 seconds ago. Okay, and the posterior surface of the petrous part is found like right here, right in the section. So this is the superior surface of the petrous part here, right here. And the inferior or the posterior section of the petrous part is hidden by the occipital bone. However, this picture should be more than enough for you guys to at least know how it looks like. Okay. Now, the temporal bone has one foramina that you guys need to know about, and it's very, very clinically relevant. Does anyone know the name of the fossa? And internal acoustic meatus. And what two main structures pass through it? Exactly. Cranial nerve 7 and cranial nerve 8. Okay. Cranial nerve 7 is the facial nerve, and then cranial nerve 8 is the vestibulocochlear nerve. And both of these are very important, as I mentioned, for you guys clinically. Also, the labyrinthine artery, but this is not that important in neuro. Moving on to the occipital bone. Yeah, one structure that you guys are going to need to identify in the occipital bone is denoted by the star right here. Can anyone at least try and guess what the structure might be? The protuberance, exactly. So you have the internal occipital protuberance, and this protuberance is important because it's also associated with the dural folds, and they will be explained later on by Reem, inshallah. But yeah, it acts as an attachment site for the dural sinuses or the dural folds. Yeah, and this is how it looks like from an anterior view. The occipital foramina are quite a few as well. However, not that hard. You have the jugular foramen, the hypoglossal canal, and the foramen magnum. The jugular foramen allows for the passage of the glossopharyngeal nerve, the vagus nerve, the accessory nerve, and the inferior petrosal and sigmoid sinuses. And that's it for the jugular foramen. Moving on to the hypoglossal canal, one nerve passes through it. Very easy for you guys. It's kind of in the name. Exactly. Cranial nerve number 12. The hypoglossal nerve, and then the foramen magnum allows for a huge bulk of the structures that are found in the skull to pass through it. Exactly. You have spinal division of the accessory nerve. You have the brainstem itself, the vertebral arteries, exactly, the dural veins, and the anterior and posterior spinal arteries. Okay. That's it for the foramina of the skull. Now, we have a little exercise. It's going to be a rapid fire exercise where I'm going to ask you guys a number of this out of this picture, and you guys are going to tell me just very quickly what structures pass through these foramina. Okay, so number 5. What would number 5 be? It's a little hard. Yeah, it's exactly. It is foramen rotundum. And what passes through it? Exactly. Not actually. It's not B3. It's the second division. Yeah, exactly. It's the maxillary division. Yeah, I understand. Okay, number 6. What would number 6 be? Yeah, it is foramen ovale. It allows for the passage of V3. One last one. 7. Onto 7B. Foramen spinosum. And what is the main structure that passes through it? The middle meningeal artery. All right. The rest of it, the rest of the labelings, you guys can find it inshallah in the notes section of the PT that I'll send later on, inshallah. We're going to be sending it later on. But it's a very good exercise for when you guys are wrapping up your studies and you just want to quickly test yourself out. And this is a small summary of everything we just talked about in terms of the summaries, the bones that are found, and the fossas. Yeah, very helpful. Now that we're done with the anatomy of the skull and its foraminers, we're gonna go over the meninges and the dural supply. Okay. Now, I just talked about the meninges. What are the meninges, and what are the 3 layers of the meninges? Okay, you have dura mater, the arachnoid mater, and the pia mater. Okay, so what the meninges are in summary, there are brain coverings that wrap around the brain in order to act like as a sort of protection, and also it helps provide it with nutrients. In simple words. As you can see here, the dura mater specifically has 2 main layers, the petrosal and the meningeal layers. And these layers are important because they allow for the sinuses to pass through. All of this will be better explained, inshallah, when Reem takes over in regards to the sinuses. However, just keep that in mind for when she takes over, inshallah. Then you have the arachnoid layer, or the arachnoid matter. And right underneath the arachnoid matter, there is this space, which is called a subarachnoid space. And this space is very important because it allows for the flowing and uptake of CSF. And lastly is the pia mater. It's a layer that's very strongly adherent to the skull itself, and it goes through the grooves and the sulci. Here is another schematic picture that better explains what I just said. The subdural space, the arachnoid matter, the subarachnoid matter, and the pia mater. It's very clearly laid out. Now, the main blood supply for the dural, or the dura, comes from the external carotid. 4 main arteries. We have the ascending pharyngeal, the occipital, the vertebral, and the maxillary. The main artery that we're going to have to take out of these 4 is the maxillary artery. It's I'm sorry. The maxillary artery is a branch of the external carotid, and it gives out 2 main arteries: the middle meningeal and the accessory meningeal. The middle meningeal is the main one that we brought up many times throughout this section, and it's very clinically relevant, and we're going to find out in a second why. And the internal carotid also gives out some branches to the dura. Lastly, we have the clinical relevance of the middle meningeal artery. Why is it so clinically relevant? The main thing that we're going to need to identify is in this area. It's called the pterion, and it's formed by the sutures that different bones in the skull form when they join together. You have the frontal bone, the sphenoid bone, the parietal bone, and the temporal bone. All of them, when joined together by the sutures in the skull, they form this area which is called the pterion, and it's essentially the thinnest area in the skull. Whenever you have trauma inflicted upon the structure that is found in the skull, it can very easily crack and get affected. Any crack or any fracture that affects the pterion internally also affects another structure, which is the middle meningeal artery, because it runs along this path as well. If anything happens to the middle meningeal artery, what would be the clinical manifestation? Shown clearly in this CT scan. Very easy, guys. Very easy question. Okay. Exactly. It's an epidural hematoma, and the main thing that you guys are gonna need to identify, if you're given a CT scan and you have no clue what you're looking at, is the lemon-shaped structure found in the scan. Okay. If it's lemon, it's epidural. Okay. If it's lemon-shaped, yani, and it's caused by ruptured MMP. Now, okay. Come on. Starting next up, we're going to start with the spinal cord. We're going to go over its anatomy. We're going to go over its histology. We're going to go over its sections. Okay. In the anatomy section, we're going to go over the vertebra and the spinal cord, the arterial blood supply and venous drainage, and then ending up with the clinical significance, really any clinical significances related to the spinal cord. Okay. The spinal cord, as anything else, as the brain, in fact, has its own home, okay? And the home that the spinal cord has is the vertebra. Now, from this structure, or from this picture right here, can anyone at least list out any major features that can be found in any vertebra, or any regular vertebra that you can see? So here, it would be the body, the vertebral body, and the spinous processes, exactly. What would this be? The structure? يعني intervertebral foramen, and then you have the bodies in the middle. Generally, you have a couple of features for any vertebra, okay? Oh my God. Sorry, guys. You have a couple of features for any vertebra. You have the vertebral body, you have the spinous processes, you have the transverse processes, intervertebral foramen, and the intervertebral disc. When it comes to the formation of the spinal cord, or how it moves through the vertebral body, these features, or these identification points, are very important for the formation of how, or the flow of how the spinal cord flows in the vertebra. I hope that makes sense. So yeah, as you can see here in this picture, okay, as you can see here in this picture, the spinal cord flows through the vertebral foramen, okay? The spinal cord flows through the vertebral foramen, and out of the spinal cord flows out spinal nerves. These spinal nerves come out of the intervertebral foramen, as you can see here, the intervertebral foramen, and the entire structure is held together by ligaments. Now, these ligaments are not that important. It comes up later. However, the main thing that I'm going to need you guys to get out of this picture is the fact that the spinal cord goes through the vertebral foramen, and spinal nerves come out of the intervertebral foramen. Okay, it should be easy to memorize, inshallah. And that's it for this slide. Now, in the spinal cord, there are various sections, or various points at which the spinal cord kind of tapers down to a point, okay? So right after the lumbar enlargement, what is the structure that tapers down? What tapers down to right after the lumbar enlargement? What do you guys think its name is? Okay, it's called the conus medullaris. Conus medullaris. The conus medullaris is a structure where all the spinal nerves just kind of merge together, forming this structure, the conus medullaris. It's a cone-like structure. And then you have the filum terminale. The filum terminale is comes in right after the dura sinuses kind of slip away. They stop covering the spinal cord, and the only dura that is left is the arachnoid matter. You have, and it forms the final terminale. The final terminale, as you can see here, it continues on and it attaches itself to the sacral process. And this all of this happens in order for it to stabilize the spinal cord effectively. Moving on, just a quick overview. We have this model of a transverse section of the spinal cord. And as we all know, the spinal cord is divided into two main parts, the white matter and the gray matter. The white matter formed by this, formed in here, the white section basically of the spinal cord, and then the gray matter inside. Yeah, sorry guys. And then the gray matter inside. Okay. In the gray matter, you have various horns. You have the dorsal horn, the anterior horn, and the lateral horn. The dorsal horn is responsible for the sensory part of the spinal cord, exactly the senses. And the anterior horn is responsible for the motor part of the spinal cord. Then you have the lateral horn. The lateral horn is responsible for the sympathetic preganglionic sympathetic section of the spinal cord, and it happens through T1 to L2 exactly. It can be found from T1 to L2. So the main thing that I want you guys to get out of this picture is the fact that there are fibers coming out of the posterior horn, and there are fibers coming out of the anterior horn, as well as the lateral horn in this case. All of these fibers merge together in order to form the spinal nerve, as you can see here. In case of the dorsal horn, the main thing that we need to take away from this is the dorsal root ganglia, exactly. The dorsal root ganglia is the main telling point that tells you that this is the sensory part of the spinal cord. It comes out of the dorsal horn, okay? Okay. Last thing, or one of the last things that we need to discuss in terms of the spinal cord is the fact that the dura that is found in the brain continues down, and it covers the spinal cord as well. And that can kind of be inferred by what I just said. And it stops at S2, exactly. That can be, it will be seen inshallah in the sections later on. However, as you can see right here, it has the main three layers that we talked about previously. The pia mater is adherent to the spinal cord, and it adheres into its grooves as well. The subarachnoid space and the subarachnoid matter, yeah. And then you have the dura mater covering it externally, yani the outermost layer. One ligament that Dr. Yaqeen emphasized on is the denticulate ligament. It can be found on either side, attaching the spinal cord to either side of the dura, formed by the pia mater, and the main job for it is to basically stabilize the spinal cord to the sides in order for it not to move or any jiggle out of place, essentially. Another thing that we need to keep in mind is the fact that the dura stops covering the spinal cord right after the merging of the fibers from the posterior horn and the anterior horn. So right after the merging, it merges right here. The dura stops covering it, stops covering the spinal nerve. And that's it for the coverings. Now, one of the things that we need to keep in mind is the fact that, one last thing before we move on. The spinal cord itself has a groove at the top, and this will be significant later on because this groove is where, it's called the anterior groove, and this is where the anterior spinal artery kind of sits. Just keep that in mind. Now, one clinical significance for the ligaments that are found in the spinal cord, in the vertebra, or surrounding the vertebra, is the fact that you don't need to memorize the names, by the way, of these ligaments. Just know the fact that ligamentum flavum is the main one that you guys are going to need to memorize when it comes to lumbar puncture. In lumbar puncture, there's a needle that gets inserted at which level, by the way, guys? At which level do you insert the needle for lumbar puncture in adults? L3 to L4. So at L3 to L4, you insert the needle for the lumbar puncture and goes through all of these ligaments until you reach the space that you want to reach, which is the subarachnoid space, in order to collect CSF. One characteristic feature of this test is the fact that it tells you at some point when you're inserting the needle, you're going to hear a pop. This pop comes from the tearing of the needle through this ligament, and it's called the ligamentum flavum. Okay? That's all this picture is telling you. Now, moving on to the arterial supply and venous drainage. Before we move on, does anyone have any questions about everything or anything that we discussed right now? Okay. Now, moving on to the arterial supply and venous drainage. The vertebral arteries are provide the main blood supply for the vertebra, or for the spinal cord, and it branches out into two main arteries. What are they? Okay, the vertebral arteries provide the main blood supply for the spinal cord. It gives out two main arteries. One of them are paired, however, there are two exactly: the anterior spinal artery and the posterior spinal artery. The posterior spinal arteries are paired arteries, and they flow in the posterior part of the spinal cord. And there's a picture that would depict that later on, inshallah. The anterior spinal artery supplies the anterior 2/3 of the spinal cord, and the posterior spinal artery supplies the posterior 1/3 of the spinal cord, and they anastomose along the way. One main artery that does supply the spinal cord anteriorly along the way is the anterior and posterior segmental medullary arteries. The main one that you guys need to memorize by heart, and the largest one, is called the anterior segmental artery of Adam Wheats, or great anterior radicular medullary artery. Memorize this by heart. It's very, very clinically important. And this artery mainly supplies the spinal cord at the level of T8, exactly. Make sure you have that in mind, please. And inshallah, yani, you'll be golden. Now, as I said, the subclavian artery gives out the vertebral artery, and the vertebral artery coalesce together right here, and it gives out the anterior spinal artery. And this anterior spinal artery gets supply or yani help from various medullary arteries along the way that come out from the abdominal aorta or thoracic aorta in this case. Okay? Now, as I mentioned before, posterior spinal artery also comes out from the vertebral arteries. Okay? 1 second, guys. Okay, sorry. Sorry for the interruption. Now, as I was saying, the posterior spinal artery comes out from the vertebral artery. It goes posterior. It gives out branches posteriorly that supply the posterior spinal cord. Okay, and yeah. Now, one thing that this brings us to is a clinical significance. Okay, so imagine with me, there is a patient that comes to you with a trauma to the T6 vertebra. First of all, what would the diagnosis be in this case? Okay, so you have a patient that comes to you with trauma to the back, okay, specifically at the T6 region. They have lower motor neuron symptoms, and they have loss of pain and temperature. Okay, they presented with these signs. Anterior spinal cord syndrome. Okay, amazing. And what would, in this picture, for example, what would the spared tracts be in this picture? Spared, the spared tracts. The spared tracts. And if, okay, the diagnosis is anterior spinal artery. Okay, the anterior spinal artery supplies the anterior part, exactly, the dorsal column. The anterior part, it supplies the anterior part of the spinal cord. And as we mentioned before, the anterior part of the spinal cord has all of these structures, or as you guys took before, it has all of these structures. The main structure that is not given, or not supplied by the anterior spinal artery would be the dorsal column. So B and A from both sides. These structures are supplied by the dorsal spinal arteries, okay? And why did they, مثلا, as I mentioned, the patient that presented to you with lower motor neuron signs. Why would that be? Why did they present to you with low motor neuron sign? What is the affected region here that would give you the reason for you to think, it's lower motor neuron signs? And this is why it's affected. The anterior horn, exactly. And what about the pain and temperature? What caused these symptoms? What damage to what tract? Lateral spinothalamic. حتى anterior, by the way. Anterior spinothalamic is right here. So both of them, both the lateral and the anterior spinothalamic would be affected. And this is why she, or the patient that came to you, presented with loss of pain and temperature. Now, you have the venous drainage of the spinal cord. Very easy. The anterior spinal vein and the posterior spinal vein. Both of them drain into one plexus of veins called the Paston's plexus, or the internal vertebral venous plexus. Okay. This plexus is found in the epidural space between the dura mater and the vertebrae. I don't believe this was mentioned in your slides, any lecture slides. So I will understand if you guys didn't know this. However, this was mentioned in your lab file. So yeah, just keep it in mind. Now that we're done with the spinal cord, and we're going to move on to the clinical cases, a quick overview, even though we had a case on the spinal cord, just a quick overview. As I mentioned before, the gray matter and the white matter, this is what divides the spinal cord. You have the white matter over here. It's called the white matter because it's full of axons. The gray matter over here, it's called the gray matter because it's full of nuclei, and that's why it appears gray. It has the posterior horn, which is mostly sensory, anterior horn, which is mostly motor. And the white matter has a bunch of tracts. The dorsal column, the spinal lemniscus, the spinocerebellar, and the corticospinal. The ascending tracts are the dorsal column, spinal lemniscus, and spinocerebellar. And descending tracts is the corticospinal. Should make sense to you guys, inshallah. Another schematic diagram, because whatever we're going to go through for the rest of the slides are going to be purely clinical, okay? So I'm going to be giving you guys a clinical case. Just help me diagnose it, and inshallah, there's going to be an explanation at the end, okay? So a patient comes to you after hitting again after trauma to the back, they presented with ipsilateral loss of all sensations, okay, and ipsilateral lower motor neuron symptoms, okay. They also had ipsilateral loss of proprioception, vibration, and fine touch. Out of everything I just said, what do you think here? Ipsilateral, by the way, whenever I say ipsilateral, so in this case, the patient presented with ipsilateral loss of lower motor, loss of proprioception, vibration, and fine touch, it's on the right side. So the right side of their body did not have, had lost its ability to feel vibrations, proprioception, and fine touch. The right side of their body had lower motor neuron symptoms, and the right side of their body had lost all sensations. What is the diagnosis you guys are thinking of in this case? Exactly. Could be Brown's cord. What led you to this diagnosis? Or what happens in Brown's cord? In Brown's cord, you have, it could be trauma related. Exactly. It's hemisection of the spinal cord. Could be trauma related. Basically, what happens is half of the spinal cord is affected. Okay. Or half of the spinal cord is just not working anymore. Okay, in this case, it's the right side. Okay, at the level of the lesion, so right here, so the patient would have loss of all sensations as well as lower motor neuron signs, which is what our patient presented with. And below the level of the lesion, you would have impaired touch and impaired proprioception, fine touch, and vibration because it's ipsilateral, and upper motor neuron sign. However, what would be contralateral would be impaired pain, temperature, and crude touch because these are stuff that are supplied by the spinothalamic tract. Exactly. And the spinothalamic tract usually intersects or crosses over at the level, decussates at the level of the spinal cord, at the same level itself. So this is why you lose you lose the feeling on the contralateral side. Okay, is Brown's cord syndrome all good? Okay, I'm gonna assume it's clear. Okay, moving on, we have another case of a woman that came to you with combined lower motor neuron and upper motor neuron degeneration. This should give you the answer. ALS, exactly. Another name for it is low Gehrig disease. Okay. It has, as I mentioned, combined upper motor neuron and lower motor neuron degeneration. The most common pathophysiology for it is SOD, exactly, SOD1 deficiency, and it's familial. And that's all you guys need to memorize from this disease or any syndrome. The last syndrome that we're going to need to discuss is when a woman comes to you, or a man, they came to you with complaining of headaches, and they came to you complaining of decreased pain sensation in their upper extremities. You do an MRI, and you find this finding. Okay. First of all, what is this finding that you can see on the MRI? It is the diagnosis is syringomyelia. However, when you look at this MRI, what can you see? What is this finding? Chiari malformation type 1. Okay. Chiari malformation type 1 is seen in this in this MRI. And as you mentioned, it is syringomyelia. However, these two are connected in a way. Does anyone know why? Why does Chiari malformation more related to syringomyelia? Okay. Exactly. It affects the CSF circulation. Anything that affects the CSF circulation due to herniation of any sort will cause, as you can see here, the central canal of the spinal cord will be affected because now the CSF will have no way to circulate through the subarachnoid space. As I mentioned, they're all connected. And this will cause the central canal to expand, and thus compressing the structures that are found in the spinal cord. The most common thing that gets affected is the lateral spinothalamic tract, because the dorsal, the anterior horn just kind of compresses it from the side. And the main symptom that the patient presents with is a cape-like loss of pain and temperature for bilaterally. So yeah, and that is it for lesions of the spinal cord. I didn't go over all of them because that wouldn't be an OSPE review anymore. However, Marwa Kidali last year, mashallah, she did an amazing lesion summary. You guys can go through them for the rest of them. However, I'm not going to go over the rest of them. Now moving over to sections of the spinal cord. Sections of the spinal cord, very simple, very easy. You just need to orient yourself clearly when it comes to you looking at a section. Okay, so you have the spinal cord right here, the vertebral column right here, and the spinal cord right here. And as one of you guys mentioned before, at which level does the spinal cord start to terminate? L1 to L2, exactly. Which you can see here. However, before we go into that, just to orient ourselves, number one is the vertebral body, and number two over here would be the spinal cord. Same thing in the transverse plane. You have number one, which is the vertebral body, and number two, which is the spinal cord. Okay, so just sagittally, you know what's happening, and transversely, you know what's happening. Okay, very easy to follow. Then, once you look at it in the sagittal plane, and clinically, you're going to need to be able to identify the numbering of the vertebral bodies. So here you have S1, L5, L4, all the way to T12. Because it would be so super hard for you to identify the structures or the vertebral bodies from top to bottom, it's advised to start from bottom to top or use the spinal cord to number. That is a good way. However, sometimes in cases of the third spinal cord, for example, it can lead to confusion. So this is why using the S1, because it's a very clear distinction. Yeah, it's a very clear distinction between L5 and S1. Using S1 or labeling it as S1 and then starting from bottom to top allows you to label the spinal cord correctly. And it's important because, as we mentioned before, the spinal cord terminates at the L1 T12, T2 level, formed by the conus medullaris, and below that the coda equina is seen, which I'm assuming you guys know what the coda equina is. And at the angle of S1 to L5, it's referred to as the lumbosacral angle. Okay, that's it for sections. Moving on to histology. We're going to cover neurons and glial cells and spinal cord with the peripheral nerves. Starting with neurons and glial cells. This is a section taken from nervous tissue. You have capillaries, glial cells, neuropils, and neurons. What would neuropil be, for example, in this section? What would neuropil stand for, or what is it? Essentially, a neuropil is the stroma that makes up any nervous tissue. Okay, so it has all the axons that make up the neurons that are that surround that are extended from the neurons. The glial cells, it makes up it contains also capillaries and so on and so forth. Now, as I mentioned, neuropils are the non-cellular component of the stroma of the nervous tissue. You also have neurons right here, very easily distinguishable, and these are the excitable part of the nervous tissue, and they do not regenerate. Once anything happens to them, they cannot regenerate. Glial cells are the supporting cells that are found in nervous tissue. They are non-excitable, and they're just present for metabolic and structural support. They can proliferate as well. Okay. Moving on, just to make sure that we're covering all. Oh, yeah, sure. Go on. So it is included. Histology is included, and especially yeah, histology is included. It's part of the OSPE. Yeah, of course. Okay. Now moving on to glial cells or neuroglia. There's a bunch of them. The ependymon cells, the Schwann cell, oligodendrocyte, astrocyte, and stellate cell. A lot of them are there for structural support or for support of some kind. This includes metabolic support, for example. This includes stellate cells, astrocytes. Astrocytes are there for more of an immune, microglia are for immune, Astrocytes are there for metabolic equilibrium. Oligodendrocytes are the Schwann cells of the CNS, the brain. And Schwann cells are found in the peripheral nervous system. Oligodendrocytes are found in the central nervous system. Ependymon cells are more concerned with the metabolic filtration of cerebral spinal fluid. And that's it. Just make sure you guys are oriented to what they are, the names for them, and you guys won't be asked to identify them under a microscope, but just make sure you keep them in mind. One more thing that you guys need to know is its embryological origin. Just quickly, does anyone remember what the embryological origin for glial cells are or is? Okay. It's kind of in the neural crest. It's the neuroepithelial cells, part of the neural crest. Okay. Is that clear? Okay. Now, the main bulk of the histology part of the spinal cord would be the neurons that are found in it. You have three types: the multipolar neurons, the pseudo-unipolar neurons, and the bipolar neurons. The multipolar neurons are also called the motor neurons. Pseudo-unipolar, general sensory, and bipolar neural are special sensory. Based off of these descriptions, where would you find the multipolar neurons? Because they're motor, you would find them in the anterior gray horn, and the pyramidal cells of the cerebellum. Purkinje cells, exactly. Pyramidal cells. Yeah. Now you have the pseudo-unipolar. This makes up the dorsal root ganglion of the spinal nerve and the trigeminal ganglion of cranial nerve number 5. Lastly, you have the bipolar neuron. Because it's special sensory, it makes up everything that is special and sensory in the body. So this includes the retina of the eye, the olfactory epithelium, and the taste buds of the tongue. And we're going to look through multiple slides to see how they look like. Okay? starting with multipolar neurons. Starting with multipolar neurons. We have three types under multipolar. You have motor neurons, just regular motor neurons. They are found in the anterior horn of the spinal cord. You have Purkinje cell bodies. These are found in the cerebellum and or the cerebral cortex, and the pyramidal cells in the cerebral cortex. Okay, in terms of identifying them, you can see very clearly that this is a cell body. Okay, and this cell body is the regular cell body that we have been seeing since foundation. Okay, it's star in shaped or circle in shape, and it has an axon coming out of it, along with a nucleus in the middle, and what was I saying? Oh, a nucleus in the middle. Okay, it should be easier for you guys to identify. When it comes to the Purkinje cell, it looks kind of like a lamp. The head is flowing downwards, and it has dendrites flowing on top, kind of like this picture. The dendrites are flowing on top, and the axon is being given to the cranial cell layer found in the cerebral cortex. So yeah, the pyramidal cells found in the cerebral cortex are going to be, inshallah, explained by Reem for you to better know how to identify it. But it does look different from the rest of the other cells, in the sense that it looks like a teardrop. And as you can see over here, it does look like a teardrop over here, مثلا, over here as well. So yeah, just orient yourself to the slide that is given to you. And generally, whenever they would ask you stuff for histology, they would give you something easy, inshallah. Don't worry, guys. Bipolar neuron are found in three places, as we mentioned, in taste buds, in the olfactory epithelium, and in the retina of the eye. The thing that they're going to most likely ask you about bipolar neurons is, rather than you identifying what each of them is, or if giving you a picture and asking you what it is, they would ask you the location for each of them. So essentially, where would bipolar neurons be found? In the olfactory epithelium, taste buds, and the retina of the eye. That's what you guys are going to be asked to know for the bipolar neurons. Lastly, pseudo-unipolar neurons. The main thing that you guys are going to need to identify here is the fact that it comes in two stains, the H&E stain and the silver stain. And the fact that this, because it comes in clusters, this is a ganglion cell. Okay, so, and the fact that it's surrounded by stellate cells. As I mentioned before, stellate cells are just there for metabolic equilibrium or metabolic regulation. Okay, and it helps the ganglion cell be able to regulate its signals and general metabolic state. Okay, this is how it looks like under silver stain, and this is how it looks like under an H&E stain. Okay, now, before we go into the spinal cord and peripheral nerve under histology, is everything clear so far? Okay. Spinal cord and the peripheral nerve. Now, one thing that is confusing in the spinal cord in the slide that they give you in your histology material is the fact that it's butterfly shaped. Generally, the gray matter in the histology slides that they give you is butterfly shaped, and generally in the anatomy it's butterfly shaped, as you can see here. However, we are used to this horn to be anterior, صح? We are used to this horn being anterior horn and this horn being posterior horn. However, this is not the case in this slide. So you're going to need to be able to orient yourself really well. I'll show you what I mean in a second. So in a second. Okay. So you have the white matter and the gray matter, very easy to identify. And you have these two structures. Ideally, because we're so used to the anterior horn being over here and the posterior horn being over here, you would think, you would immediately answer, no, this is the anterior horn and this is the dorsal horn. However, that is wrong. As you can see here, the dorsal horn is more tapered towards the end, and it kind of merges with the sides of the spinal cord's edge. You know what I mean? And then the ventral horn is more circular at the bottom. Okay, so this would lead us to the identification of the structure denoted by the yellow star being the anterior horn, and the structure denoted by the blue star being the dorsal horn. So you guys need to pay attention whenever you are looking at the structure at this picture, because it can be confusing and they can trick you using this. Okay, and I think this came as a question for us last year, and a lot of people were confused by it. So just keep it in mind whenever you're looking at a cross section, a histological cross section of the spinal cord. Start by orienting yourself which parts or which structure is the gray matter and which one is the white matter, and then identifying the anterior horn and the posterior horn, or the dorsal horn. Does that make sense? Is this clear? Okay. Now, wow. Okay. Moving forward, just to be able to identify, you have in the white matter, you have generally, as I mentioned before, myelin sheath, because you're going to have the axons for the cell bodies. So it's going to have myelin sheath. You're going to have the axons denoted by the A and the blood capillaries. All of them, you're going to be finding it in the white matter. No cell bodies in the white matter, okay? Or any actual stroma, just the axons, myelin sheath, and blood capillaries. And that's it. In the gray matter, as I mentioned before, you're going to find the actual neuronal cell bodies, and its stroma. Okay, so in the neuronal cell bodies, you're going to see, this is how it's going to look like. Okay, you're going to see dendrites, you're going to see the axon, which is going to go over into the white matter, and neuroglia surrounding it. Okay, same thing here. Okay, you're going to see the neuronal cell bodies with the N in the middle denoting the nucleus, dendrites coming out of the sides. These are neuroglia as well. The axons are going to be coming out of one end. And yeah, just make sure to be able to identify these structures. And lastly, this picture just shows you the spinal cord under a different stain. Yeah, yellow stars for anterior, posterior, cranial. Oh, let's go back. Okay, the yellow star would be for anterior gray horn. Okay, and you have the posterior gray horn over here, or the dorsal gray horn, because as I said, it's, as you can see in this picture, the dorsal horn kind of tapers to a point at some point. Okay, it tapers to a point, and this is just a way for you guys to identify and be able to identify it when you see it in a question in the final. Okay, it tapers to a point. However, the ventral horn kind of just has a smooth appearance at the bottom. Okay, it doesn't taper. And this is just a way for them to kind of trick you in a question. So just keep that in mind. So if given a question like this, it's going to be very easy for you to identify it. Okay. Now, last thing that we're going to need to talk about is the spinal cord under silver stain. Okay. Very similar to what we saw under H&E stain. This is the dorsal or the gray matter, and this is the white matter. In the middle is the commissure. You have the anterior horn, the posterior horn, and in the anterior horn, because it's a motor section of the gray matter, you're going to see neurons, neuronal cell bodies to be precise, and glial cells, nucleus, dendrites, so on and so forth. The neuropil, or the stroma, in the gray matter, looks a little bit chaotic. However, very similar to how it looked like in the under stain. And that is it for spinal cord. Moving on to peripheral nerve. This picture in specific, and a picture that looks very similar to it, came in our OSPE, and a lot of people were confused because I'm gonna show you the question later on. Inshallah, it comes on later throughout the slides. But just keep in mind that they can ask you for the peripheral nerve, even though they didn't give you in the slides a clear picture for it. Okay, and this is gonna come up as a question later on, inshallah. However, the main thing that we're gonna need to take out of this picture is the fact that the peripheral nerve in general has 3 coverings. Okay. What are they? They're kind of listed here. However, I want you guys to list them in order, from innermost to outermost. Exactly. So you have the endoneurium, which covers the main axon, and then you have the perineurium, perineurium, and lastly you have the epineurium. The epineurium just covers a whole bunch of fascicles together. Okay, this is them in order, and lastly you have the peripheral nerve under stain. Because this is a very important topic for you guys to be able to identify, I'm going to start and go back to the slide and realize the fact that the axons in the middle of this is a transverse section. So the axons in for each neuron is denoted by the pink circle right here in the middle. Okay, and then whatever is wrapping up around it is the myelin sheath. And you can find this out by the fact that there is a nuclei in the middle or on the sides at the periphery of the sheath. Okay, and this is because whenever the myelin sheath wraps around the axon of the neuron, it kind of squishes itself and it appears squished and lateral to on the side. Okay, keep that in mind because it comes up in identification later on. Now, this is a cross-section of the nerve. As we mentioned before, you have this nerve right here. This would be the little pink dot in the middle. Okay, this would be the axon for the neuron, and then you have for the nerve, and then you have for the neuron. Yes, this would be the axon for the neuron, and then surrounding it would be the myelin sheath. Okay. On this picture as well, you would see that endoneurium. The endoneurium can be found over here because it's covering the individual fibers, and then the perineurium can be found surrounding the big fascicle. Okay. Because that was a cross-section view, over here we have a longitudinal view. So it can be a little disorienting. Let's orient ourselves first before starting. We have longitudinal view of the nerve fiber. Yeah, you have an axon in the middle, which is the same thing as the pink circle that we saw in the middle of the previous drawing or the previous picture. The axon in the middle, and then you have a node of Ranvier between each myelin sheath, as you can see here. This is a myelin sheath. This is a myelin sheath. In the middle, there's a node of Ranvier, and this is important for saltatory conduction of the myelin fiber. And CO is collagen, basically. Another picture over here gives you a view of the peripheral nerve fiber. Over here, this is a nerve fiber. There's the axon for it. The myelin sheath is wrapped around it, and you have for Schwann, the myelin sheath of the Schwann cells. And in the middle, you have a node of Ranvier. The node of Ranvier is more clearly shown over here. However, you get just the gist of it. Yeah, that's it for both the spinal cord and the skull. Now, I'm gonna pass the stage over to Reem.
Okay, so again, to reintroduce myself, my name is Reem Ahmed. I'm a third year medical student, and I'm going to be taking the portion of Cerebrum and Brainstem, inshallah. Again, if you guys have any questions, you guys could put it in the chat instead of unmuting yourselves. So everyone again has a chance. And yeah, it's going to be quite a long section for Cerebrum specifically, so bear with me. I'm hoping you guys still remember your Cerebrum content and your Brainstem content because this was all pre-midterm material. If not, that's fine. We can review together, okay? Let's start. So we have anatomy, and we're going to be speaking about different parts in anatomy. The meninges, the ventricular system, and the dural venous sinuses, the cerebrum basal ganglia, and the blood supply, okay? Let's do an overview again on the meninges because it is important not just in the spinal cord, but also in the cerebrum, okay? Again, what are the layers of the meninges? Okay, الدورة, arachnoid, والpia, exactly. And this is a simpler picture where the dura is the thickest and outermost layer, and it is divided into two more layers, which is the periosteal and the meningeal layer. We also have the arachnoid matter as well as the pia matter, okay? Between the arachnoid and pia matter, we have the subarachnoid space, which the CSF flows into, or flows in, and the dura matter, between its two layers, we have the sinuses, which we will talk about later, okay? This is everything I said in text. Now, more specifically that I want to talk about is the folds of the meninges. Does anyone know or can name any folds that we have of the meninges? Tentorium, cerebelli. We have four, I'll give you a hint, we have four folds. Falx cerebri, the third one. Falx cerebelli, and we have the last one. Okay, it's okay. We have the diaphragm ocella, okay? The tentorium cerebelli, falx cerebri, falx cerebelli, diaphragm ocella are all the folds of the meninges, specifically the dura, okay? We have a picture over here that shows us the folds. This fold over here is the falx cerebri. The falx cerebri attaches anteriorly عند الكريستا galli and posteriorly مع التنtorium cerebelli, okay? It is going to basically divide our cerebrum into its left hemisphere and its right hemisphere. So it goes in between the two hemispheres of the cerebrum, okay? Tentorium cerebelli, which is these structures over here, it basically makes a tent over the cerebellum, and it divides or separates its cerebrum from the cerebellum, okay? We don't have a picture over here for the rest of them, but falx cerebelli, just like the falx cerebri, it is going to go in between the two cerebellar hemispheres and divide them into their left and right structures. And then we have the diaphragm ocella, which is a fold of meninge that is in the pituitary gland. It's going to keep just a little bit of space for the hypothalamus to go through, okay? We have another picture over here, a real picture of the falx cerebri. As you can see, it's retracted from the medial portion of our cerebrum. And then, as I said, the sinuses are embedded into the dural folds. So as we can see here, we see the sinuses, which we will talk in detail about in a little bit. And it is in between dural folds, okay? This over here would be the tentorium cerebelli, okay? Now this is another image, just a real image. I think it's very important to look at real images of what you're studying so you can actually understand and visualize it in a real human brain, rather than just schematic images. So this is just to add in there. Tamam. Now let's go into the ventricular system with dural sinuses. I heard إنه Dr. Akif canceled the lecture for you guys. We had a lecture on this last year, but I heard it got canceled. I'm going to be explaining this in as much detail as I can to help you guys, because this was explained in detail in lab, and I also heard that most of you guys did not attend lab, which is okay. So I'm going to go through with this, and then we're going to have some practice questions. Now, some embryology first. We know that we have the primary vesicles, which is prosencephalon, mesencephalon, rhombencephalon. These primary brain vesicles are then further divided into the telencephalon, diencephalon, mesencephalon, meta, and myelencephalon. Okay, these brain vesicles will give rise to certain structures in our brain, and it is very important to know their associations, not just for OSPE material, but also in MCQ material. They can very easily ask you a simple recall question, and it's the easiest answer ever. If you just don't know it, you won't get it. Okay. We know, or we should know, in the telencephalon gives rise to the lateral ventricles, which is in close association with our cerebrum. Okay. Our diencephalon gives rise to our third ventricle, which is in close relation to our thalamus. Myelencephalon gives rise to the cerebral aqueduct, or contains the cerebral aqueduct, which is in relation to our midbrain. Metencephalon myelencephalon gives rise to the fourth ventricle, which is in close relation to our pons and cerebellum. Okay, and then these ventricles will go down and continue as a central canal in the spinal cord. Okay, tamam. Okay, now let's go over the actual ventricles. I know the text is all there and everything, but I want you to also tell me what the structure is. It's a big structure in the middle of our cerebrum. It's there. It's literally there. That's our lateral ventricle. No, this is our lateral ventricles. Corpus callosum is above the lateral ventricle, okay? These are our two lateral ventricles. They are paired structures. We have an anterior horn in the frontal lobe. We have a posterior horn that extends into the occipital lobe. And then we have an inferior horn in the temporal lobe. This is our biggest ventricle out of all ventricles. It's going to go down through what foramina? The foramen of Monro, exactly. It's going to go into the third ventricle, which again, what was its association? It's associated with what structure of the brain? Okay, the thalamus. The third ventricle is in close relation with the thalamus. It's then going to go down which foramina? This one over here. Cerebral aqueduct of Sylvius. And then it's going to open up into the fourth ventricle, which is in close relation to what structures? This structure over here and this structure over here, which is the cerebellum and the pons. Okay, exactly. And then it's going to open up into three foraminas, which are the foraminas of Lushka. There are two paired structures as well, and the foramen of Magendie. Tamam? Tamam. This is just a little map or something. And the lateral ventricles will go through the foramen of Monro into the third ventricle, which is in relation to the thalamus. And then it's going to open up into this aqueduct of Sylvius to the fourth ventricle, which is in association with our pons. And then the foramen of Lushka and foramen of Magendie. Okay. It has a clinical significance. I wish I remembered because I wanted to ask, but it's okay. The clinical significance of these ventricles is that anything can compress them, or there could be certain problems in certain areas that can compress the outflow of the CSF fluid, okay? For example, if you have a tumor that arises somewhere in the brain over here and it compresses the aqueduct of Sylvius, the outflow of the CSF will be obstructed, meaning that CSF is going to accumulate and cause something called the hydrocephalus. Okay, hydrocephalus is just accumulation of CSF in the ventricles, and then it causes like a very big brain. Okay, this is one association or clinical factor I want you guys to know about the ventricles. Tamam? Tamam. Now let's actually label what you guys need for lab. And these are stuff I got from you. Let's start over here with this arrow. What do these arrows depict, or what are these structures? lateral ventricles. تمام. And then we have this structure over here, which is third ventricles. And then we have this structure over here, which is the fourth ventricle. And then we have this structure over here, or C. What does C show you? The cerebral aqueduct of Sylvius. And then we have this foramina over here, which is two foraminas on either side. What's this foramina? Lushka, foramen of Lushka. And then we have one foramen over here, Magendi. And then we have this little structure over here that continues down. It's the central canal of the spinal cord. Tamam? Yes. Tamam. Now, very, very briefly, as I said, I already explained the actual flow of the CSF into the ventricular pathway. After it leaves the foramen of Magendi and the foramen of Lushka, it is going to circulate in the subarachnoid space, in the spinal cord and in the brain and whatnot. And then obviously there's going to be a lot of waste in that CSF and it needs to be drained. How does it get drained? When it goes all the way up here in the cerebrum, it's going to get absorbed by something called arachnoid villus or arachnoid granulations. These arachnoid granulations will then just take away all the CSF that needs to be drained, and it's going to be drained into the superior sagittal sinus. Okay? And then from there, خلاص, it just gets circulated, and then the choroid plexus is going to continue to produce CSF that is needed for our brain and our spinal cord. Okay? تمام. Now into the venous sinuses. I want you to focus with me here because this is the part where I would assume wasn't really taught in your actual lectures. So what the venous sinuses are, they're just a bunch of veins in your brain that drain everything that the brain needs to drain, okay? And it's a big system and it's they're all connected to each other, okay? You need to know what drains into what and where they all end up draining into, because these are all tributaries of one big vein, which is the internal jugular vein. Everything ends up draining into the internal jugular vein. Okay, let's start off from the top. I already said, this is the falx cerebri. Okay, in the superior portion of the falx cerebri, you have the superior sagittal sinus. Okay, this superior sagittal sinus goes from the very front up until the very back. Okay, there's one vein that drains into the superior sagittal sinus, which is called the superior cerebral vein. Okay, so just imagine it drains here into the superior sagittal sinus. Okay. On the inferior portion of the falx cerebri, we have the inferior sagittal sinus. Okay, this inferior sagittal sinus will drain into the straight sinus. The straight sinus basically moves posteriorly and inferiorly. Okay, and then we have another vein over here called occipital sinus. It comes up from the foramen magnum up until this occipital point over here. What I want you to know specifically and very importantly, this point here is very important. It's called the confluence of sinuses. There are three veins that drain here: the superior sagittal sinus, the straight sinus, and the occipital sinus. They all drain to one point, which is called the confluence of sinuses. Tamam? Up until here, is it clear? Okay. Tamam. Out of the confluence of sinuses, we have two more sinuses that come out of it, which are the two transverse sinuses on either side. Okay, these transverse sinuses will obviously go transversely, and then they're going to become the sigmoid sinuses, which are basically S in shape. That's why it's called sigmoid. And then that sigmoid sinus will then drain into the internal jugular vein. Okay, this is one system basically. Okay. We have another system called the cavernous sinus, and it's actually very, very, very important, and I will get into it in a little bit. This cavernous sinus is just a venous plexus, okay? This venous plexus, there's a couple structures that also drain into it that are clinically important. We have three veins: the superior ophthalmic vein, the inferior ophthalmic vein, and the sphenoparietal sinus. Okay, the sphenoparietal sinus runs along the lesser wing. The superior ophthalmic vein drains your upper portion of your eye. The inferior ophthalmic vein drains the lower portion of your eye and kind of your maxilla. Okay, these drain into the cavernous sinus. طيب, what drains the cavernous sinus? Two veins, and they're paired. Superior petrosal vein و inferior petrosal vein. Okay? A superior petrosal vein is going to drain into the transverse sinus, while inferior petrosal vein is going to drain into the sigmoid sinus. And here now we have a big connection. Okay? Is this all clear? We're going to repeat it a couple times right now, and you guys are going to help me identify certain things. Is this all clear? Or do you guys want me to repeat the cycle again? تمام. Let's go into a clearer picture, and you guys can help me identify. What is this sinus over here? This big sinus. Superior sagittal sinus. صح. طيب. What's this sinus over here? Okay. Inferior sagittal sinus. The sinus that drains, like what does the inferior sagittal sinus drain into? Which is this one over here. The straight sinus. صح. And then we have the point over here at which these three veins drain into. ايش اسمها? Confluence of sinuses. تمام. What does the confluence of sinuses give out? Transverse sinuses. And then what would this be? This over here. Cavernous sinus. And the cavernous sinus is drained by what structures? One that's over here, the other isn't shown. It's drained by two veins. What are the two veins? Inferior petrosal and superior petrosal. صح. تمام. These are the same labelings. So again, the pathway is superior sagittal sinus, inferior sagittal sinus. The inferior sagittal sinus drains into the straight sinus. And then we have the occipital sinus. These three veins drain into the same point, which is called the confluence of sinuses. The confluence of sinuses will then give out two more sinuses called the transverse sinuses, which then become sigmoid sinus and then becomes the internal jugular vein. Okay? The cavernous sinus, there are three important veins that drain into it: superior ophthalmic, inferior ophthalmic, and the sphenoparietal sinus. Okay? The cavernous sinus is then drained by two more veins, inferior petrosal, superior petrosal, which then eventually drain into the internal jugular vein. All clear? تمام. This is a table that I got from KenHub. KenHub is generally a really nice resource to use for anatomy, and it's just a little summary that I have in here. Now, talking about the cavernous sinus, because it is very important clinically in this block and the next block, okay? What's the cavernous sinus? Is just a large venous plexus, a bunch of veins that have come together, and it's found in the sella turcica, on either side of the sella turcica. What's significant about the cavernous sinus is that it's not just a venous plexus. There's a bunch of other important structures that run along with it. We have the internal carotid artery, which we will talk about later in the blood supply. And then we have important veins important nerves that run along with it. Think of it as it's mostly the nerves of the eyes, which is oculomotor nerve, trochlear nerve, abducens nerve, V1 branch of the trigeminal, which is the ophthalmic nerve, and V2. Okay? There are five nerves, صح? Four of them supply the eye, and then the other one supplies the maxilla right under the eye. Okay, so that you never forget this. Okay? Why is this important? Is because, okay, before I say the clinical significance, can someone tell me what the clinical significance is? Okay. basically it is the deep vein thrombosis, okay? An infection or a deep vein thrombosis in the nerves that, or in the veins that's like drain into the cavernous sinus will cause this clinical significance. So the clinical box, as I said, in the superior ophthalmic vein drains the upper portion of the eye, while inferior ophthalmic vein uh, drains the lower portion of the eye and the maxillary area. طيب, how would I get an infection or a deep vein thrombosis there? The superior ophthalmic vein is kind of close to your nasal area, okay? And this area is the dangerous zone or the dangerous triangle of the face. So if you pop a pimple or if you get an infection or cut somewhere in this dangerous zone of the face, it's going to be drained by the superior ophthalmic vein. You can get an infection or thrombosis that reaches the cavernous sinus. Same thing with the inferior ophthalmic vein. They can get you a case of this person has just taken out her upper molar tooth and it wasn't closed مثلا like nicely or perfectly. She could get an upper molar tooth infection that travels up the inferior ophthalmic vein and gets into this cavernous sinus. So why is that important? Is because one, thrombi are bad in general. Two, it will compress the important structures that we have over here. For the person is going to come with a history of infection somewhere around the dangerous triangle of the face or an upper molar tooth extraction, and then they're going to have signs and symptoms of like eye problems. Their eyes deviated in a certain way that isn't letting them see properly. And if you do the cranial nerve exams, you would figure out, and it's mostly the eye nerves. Okay, so you can make a diagnosis from there انه it's deep vein thrombosis or infection. تمام? Is this all clear? Okay. تمام. Perfect. This is a little summary, little mind map that I did. When you do this lecture, I think it's helpful to write down everything and make down a mind map of what drains into what, because it like clears up things in your head. Okay? تمام. Now let's get into the cerebrum, and this part is the long part. I'm hoping you guys remember so you can help me get through this a lot quicker, okay? Now, when we talk about the cerebrum, generally we have lobes, okay? And these lobes carry out different functions. We have a frontal lobe over here, parietal lobe, occipital lobe, temporal lobe. طيب. What divides these lobes? Sulci. What's this sulcus over here? The sulcus is the central sulcus. What's this sulcus? The parieto-occipital sulcus. And this sulcus over here is called the lateral sulcus, okay? The central sulcus divides the frontal lobe from the parietal lobe, while parieto-occipital divides the parietal from the occipital, and the lateral divides the temporal from the rest of the structures over here, the frontal والparietal. تمام؟ تمام. Can it move? Okay, now an actual real version of the brain. No, sorry. Okay, I hope you guys did not see it. We have a lateral view and a medial view of the brain. This over here is the central sulcus, تمام? Frontal lobe, parietal lobe, occipital lobe, and temporal lobe. And how could you look at a real brain and be like, that's the central sulcus? When you look at an actual brain and you actually examine the different sulci, you actually see that the central sulcus is the largest sulcus out of all of them. Okay, so this here would be the central sulcus. And if you look at the brain long enough, I think you can already tell. Okay, now what's this gyrus over here before the central sulcus? This gyrus, the precentral gyrus, and this gyrus, the post-central gyrus. صح, تمام. الحمد لله. Now let's look at the medial structures of the cerebrum. As we said, this is the frontal lobe, the occipital lobe, parietal lobe. What is this gyrus over here that is above the corpus callosum? I just gave you an answer, معلش. But this gyrus over here. is a cingulate gyrus. Above, somewhere over here, or it's this structure, um, is the corpus callosum. This cavity over here, what's the cavity? Lateral ventricle. I believe it's the lateral plus the third ventricle because I can't see the third ventricle, but generally it's lateral ventricle. What's this structure over here? This big, big structure? The thalamus. Underneath the thalamus over here, what would that be? Not hypothalamus would be somewhere anteriorly over here, but this structure over here, it's part of the brainstem. The pons, exactly. The midbrain would be above over here. The pons would be somewhere. Oh, I think actually no. This is the midbrain. So this is the pons. The pons is huge because of the peduncles. Sorry. Yes, sir, you're right. Okay. So hina would be the midbrain. Hina would be the pons. Okay. I've labeled it for you guys. Just to make it a little bit easier for you. Okay. Now, let's get into the functional areas of the cerebrum. Just a general overview. I'm not going to be speaking about every single gyrus. I have a summary table ahead, but I want to speak about 4 different important structures of the cerebrum that you should know like the back of your hand. Okay. It's the precentral gyrus, the postcentral gyrus, this area over here, and this area over here. Okay. Now, the precentral gyrus, can anyone tell me the function or the general function of the precentral gyrus? Okay. Primary motor cortex. It is the primary motor cortex, but what does it specifically do? It helps initiate movement, motor movement that you're gonna do. Okay. What helps it is this gyrus over here, which is the premotor cortex. It helps um, complex movements. Okay, so if you're gonna ride the bicycle or if you're gonna use a screwdriver, this complex movement that you're about to do is helped by the help is coming from the premotor cortex. Okay, the postcentral gyrus over here, which is the sensory area, as the name applies, it's responsible for every single sensation you know. Pain, temperature, to touch, discrimination, conscious proprioception, all that stuff. So it's all given over here, okay? This area over here is called what area? It's very important. يعني out of this, you need to know this part. It's in the Broca's area. What's Broca's area? Does anyone know what Broca's area does? Okay, so it's basically responsible for your exactly motor part of the speech. It helps, form the words, form the sentences like the way you say things and the way your mouth moves and the way your vocal cord move and all that stuff is because of the Broca's area. Okay? The Wernicke's area over here is responsible for what part or what exactly? Okay, it's responsible for the comprehension part of the speech. So I'm hoping you guys can understand me at the moment because if you understand me, that would mean that your Wernicke's area is intact and it's working. Just the way everything makes sense, whether it's written, whether it's said, whether it's whatever it is, it's for comprehension and understanding of what the person is saying or reading or writing. Okay? These are the most important parts of the cerebrum. Now, the homunculus is also extremely important, okay? You have a motor homunculus and you have a sensory homunculus. They generally cover the same areas. But first of all, what is the homunculus? The homunculus is an area in your brain, which is the post or the precentral gyruses. And they have it's basically an exact mind map of your contralateral body, okay? Thumb is the most important part. I believe so, yes. What was I saying? Yeah, so it has an exact image of your contralateral body. Contralateral is important, okay? So my right side is responsible for my left side, and my left side is responsible for my right side, okay? And every single part of the gyrus represents something on the body. Generally speaking, the medial side of the homunculus, which is over here, represents your lower half of the body, and the lateral side of the homunculus represents your upper part of your body, okay? And it's very important that you also know its blood supply, which is coming up later, but just to reiterate or mention here, the middle part or the medial part of the homunculus is supplied by the anterior cerebral artery, and the lateral part is supplied by the middle cerebral artery. Okay? So if I were to open someone's brain right now and يعني مثلا like stimulate this area over here, he'd have sensations in his hands. Okay? The homunculus is also disproportionate, and I forgot the term exactly, but إنه not every single part of the body has the exact same measures as another part of the body. So you can see here that the hands have a big part as compared to, for example, the elbow. Okay? It's very disproportionate. And this is why sensations in our hands are a lot more precise than, for example, my shoulder. Okay? Does that make sense? Is the homunculus clear? تمام. This is also the homunculus if we are presented by different areas of the brain and how much a certain organ covers in the brain. This is the little man in our heads. Okay. Now, this slide is just put here because it's very nice to actually finish the lecture and then actually draw it out and test your memory on it. At the same time, you're literally testing your hippocampus, which is something that you guys learned. I think it's very cool, and I think you guys should like actually draw it out as part of your review, because it just helps your recall. Okay. Now this is the little like summary that I did. I did this summary and this summary and this summary. Different colors represent different parts of the brain. So the red color would mean it's the frontal lobe. It's placed in the frontal lobe. The blue would be the parietal lobe. Green would be temporal. Yellow would be occipital. Okay. However, because we mentioned the Broca's area and the Wernicke's area and stuff, I want to go over the lesions because again, it's very important. So we have a primary motor cortex that we talked about. We said that it carries, or that homunculus carries out all the motor functions in our body. If anything is like, if damage happens to that cortex, or if we have a stroke in the artery that supplies it, you will have an upper motor neuron lesion. Upper motor neuron. That's very important because why? Like, what is a characteristic finding of upper motor neuron lesions? What is something you would see? Spastic paralysis, exactly. And this would happen on the contralateral head and body. So literally half of your body would be in would be in spastic paralysis, okay? With positive Babinski sign and all that stuff that you know about, okay? For Broca's area, if it is damaged, because we said it's responsible for your motor part of your speech, the patient, if it's damaged, if Broca's area is damaged, the patient won't be able to actually say literal words, but they can understand you. Okay? So if you're talking to them, they understand you, they just cannot talk normally, like the way they can't make words, okay? But the patient here is aware, okay? They know that they can't speak properly, okay? For your primary somatosensory cortex, as we said, contralateral side of the body, you would lose every single sensation from pain, from temperature, conscious proprioception, to touch, all that stuff. Okay. And then we have Wernicke's area. And as we said, Wernicke's area is part of your comprehension. So if the patient, has damage to Wernicke's area, they'll be able to say words. Their words are literal words, but they can't make sense of it. They can't put it in a actual sentence. So they just throw out random words, which is called word salad. And the patient here is not aware. Okay? Tamam. I think, yeah, that's it. This is, by the way, a QR code of the PDF for the summary. Okay? Okay, so is the functional areas of the cerebrum يعني is it okay? Is it clear? تمام, perfect. Now let's go into the basal ganglia. I won't be speaking much about the basal ganglia because the basal ganglia نفسها, it's a very complex part of the brain, but generally يعني it's just a bunch of nuclei that are found in our subcortical region, and it's made up of a bunch of nuclei that are all attached together and sending signals to each other. But what does the basal ganglia do? Does anyone know? Okay, so the basal ganglia is basically, okay, I was asking, what does the basal ganglia do generally? Okay, it helps with your motor function. So it helps, it kind of helps correcting, not as much as the cerebellum, but it basically helps you to not always be in a state of involuntary actions. So if I'm resting and I'm just like chilling, I would like to just chill and be, يعني, just like not really moving. The basal ganglia allows that to happen. It doesn't allow me to have jerky movements, just moving my hands without wanting me to. For the basal ganglia are always constantly sending out inhibitory signals to the thalamus so that we don't do involuntary actions. We have two pathways in a nutshell. There's a direct pathway, there's an indirect pathway. The direct pathway makes it easier to initiate the movement that we want, and the indirect pathway is there to inhibit any movements that you don't want to do. Okay? So let's go into the actual basal ganglia. We have these structures, okay? Striatum, globus pallidus, substantia nigra, and subthalamic nucleus. We're not going to go through every single one of them. However, I want you to know their orientation in the brain, okay? So they're in very close relation to our lateral ventricles. So we have the lateral ventricle over here, tamam? Underneath the lateral ventricle, we have the caudate nucleus, and it's like a little C, okay? We have the head over here, we have the body, and we have the tail, okay? At the end of the caudate nucleus, we have the amygdala. Does not concern our topic now, it concerns you in psychiatry. Tamam? And then you have within the C of the caudate, you have the putamen, okay? And then with the putamen, you have also the globus pallidus. If you can look over here, you have the putamen, okay? And then when you go medially, you have the globus pallidus, externa and interna, okay? The substantia nigra is part of our midbrain, which we will talk about later. And then we have the subthalamic nucleus. For your OSPE, I think you just need to know that they exist and where they're placed, and we're going to look at cross-sections of them. Tamam? Now, this is a superior view of the same thing, okay? So again, to orient ourselves, this is the anterior and this is the posterior. As we said, it's in close relation of our lateral ventricles, meaning that I would see the lateral ventricles in the section I want to look at the basal ganglion. So you have the lateral ventricle over here, okay? And then the most medial structure would be the thalamus, and it's huge, okay? I don't think you can ever miss a thalamus. You have the caudate nucleus over here, which is the head of the caudate nucleus. And then you have the putamen. As I said, if you look here, this is the putamen. If you go more medial, you see the globus pallidus externa and the globus pallidus interna. They're very, very close structures. Tamam? What is found between the thalamus and the putamen? It's a very important structure, and it's written over here. This purple structure. The internal capsule. The internal capsule is super, super, super important in the sense of it carries out every single ascending and descending fibers coming or going from the brain. Okay? So a lesion here would be disastrous. Disastrous. Okay? This internal capsule, again, is between the thalamus and the putamen, or a lentiform nucleus. This is called lentiform nucleus as a whole. Okay? You have a posterior limb, an anterior limb, and a genu. Okay? Tamam. Between the putamen and this structure, which is called the claustrum, you have another part or another capsule over here, which is called the, if you guys can, external capsule. Okay, between the lentiform nucleus and the claustrum, we have the external capsule. Okay. And then you have other structures that I don't think really concerns you in this part or in OSPE, but you need to know their orientation and how they would look like in a section. Okay? So again, between the thalamus with lentiform nucleus, you have internal capsule. Between the claustrum and the lentiform nucleus, you have the external capsule. Okay? Now let's look at actual pictures and real images from your OSPE lab. These are some structures we didn't really discuss in basal ganglia, but again, if you can point them out, that would be perfect. What are these two cavities? These cavities are the lateral ventricles. Tamam. And then, yes, the lateral ventricles. Over here, what would you see? This little portion over here that's in front of the lateral ventricle. Not the caudate. The caudate would be higher. هنا ما في any basal ganglia stuff. This would be the nope. This is the thalamus. This is the splenium of the corpus callosum, and here would be the genu of the corpus callosum. Okay, the corpus callosum goes above the lateral ventricles. So we would also see part of it with the lateral ventricles. So splenium, which is the anterior portion of it, and the genu, which is the posterior portion of it. Tamam? This would be the thalamus. Okay, and over here would be the septum pellucidum. If you guys know, the septum pellucidum divides between the lateral and the not the lateral, the right and the left lateral ventricles. Tamam? Okay. Okay, this depicts the same thing. Now, yeah, basically it depicts the same thing. Okay. Now, if you can look over here, this is I think a lower section. As I said, in the caudate nucleus is right next to the lateral ventricle. If you can see or compare it here, you don't see the caudate nucleus. Okay, this is the head of the caudate nucleus. And then over here we have the thalamus. Tamam. And then here we have the lentiform nucleus. So you'd have the putamen, globus pallidus externa, globus pallidus interna. And then between them, if I'm like marking it with my arrow over here, that would be the internal capsule. Okay? Is this all clear? Is it clear or do you guys want me to repeat? Okay, tamam. Now, let's go into some clinical with the basal ganglia. I'm going to give you a case. So let's say a 70-year-old man just came to my clinic and he's complaining of shaking of his hands and he just feels like he's so slow he can't walk. This is super easy. This is a classical case. Parkinson's disease. He looks like this. And then when you look into his brain, or if you look into his brain, you see that his substantia nigra is diminished. Okay. What's diminished in Parkinson's disease? What neurotransmitter is depleted? Dopamine. صح. Mashallah. So TRAP is associated with Parkinson's. If anything you need to know about Parkinson's, memorize TRAP. It is very important to, if you don't have dopamine, that means you don't have any movement. Okay. Now, another case of another man, he feels like he has so many jerky movements and it's just super involuntary. And he kind of looks like this. Like this is kind of Huntington's disease. Huntington's disease would be, what's the structure that's diminished? The caudate or the putamen. And you would see that his lateral ventricles are huge. Why? Because if the caudate nucleus is diminished and it's basically shrinking in size, that gives more room for the lateral ventricles, or it basically pulls the lateral ventricles to make it a lot bigger. Okay? Are these clear? Come on, in Parkinson's disease is basically actually never mind. Okay. خلاص تمام. Now let's get into the blood supply. I'm gonna try to speed through this. And hopefully you guys know the blood supply. Let's go into the cerebral blood supply. So when we say blood supply of the head, we just think it's a huge basically anastomosis and connection. Okay, we have two areas or two circulations that connect with each other. Okay, we have the vertebrobasilar arteries and we have the internal carotid arteries. Okay, what circle does this make? What's the connection called? The whole thing in the brain? Circle of Willis. Tamam. If we look at what concerns the cerebrum, it's the anterior cerebral supply, which is the internal carotid artery. Whatever concerns the brainstem is the vertebrobasilar, which is the vertebral arteries. And we'll get through that when it gets to the brainstem area. Okay? The internal carotid artery. Okay, first of all, we have the aorta, and it gives off its branches. When it gives off its branches, it's going to give you the common carotid, which then bifurcates along C3 and C5. Tamam? It's going to give you two branches. What are the branches? Internal carotid artery and the external carotid artery. Exactly. When you look at the pathways of these arteries, you'd find that the external carotid artery goes up to the face and branches immediately. The internal carotid would follow its pathway along the neck, continue to go up without branching until it enters the structures of the brain and then starts to branch. Okay? And we'll talk about its branches right now. Okay? Now, just to take this back and show you guys, this is the common carotid artery. It splits into external and internal carotid arteries. External carotid artery immediately branches into the structures of the face. Internal carotid artery would continue to go up, 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 up until it enters through the internal carotid canal, as Ghedaa mentioned earlier, and then it's going to supply the structures of the brain, okay? And to bring back this picture, as we said, the cavernous sinus contains the internal carotid artery, okay? So again, to reiterate, if there's any problem with the cavernous sinus, it could affect the internal carotid artery, causing ischemia, causing stroke, causing whatnot, okay? So, now let's actually look into the circle of Willis, or the anterior cerebral supply. Now, we have three major branches that come out of the internal carotid artery to supply the anterior cerebral portion of our brain. Okay? We have anterior cerebral artery, middle cerebral artery, and posterior communicating arteries. Okay? These are its major branches. Few minor branches that I won't be speaking about, but they do concern your MCQs and your probably SAQs. Okay? Which are the ophthalmic artery and the anterior choroidal artery. Okay, now let's get into the major branches one by one. Okay, the anterior cerebral artery, or sorry, middle cerebral artery, is a direct continuation of the internal carotid artery. So you see over here, this is the internal carotid artery. As it moves along, it's gonna become the middle cerebral artery. Now this is bad. Why do you guys think this is bad? It's bad because if there was any stroke or any thrombus or anything that affects the internal carotid artery, exactly, it's going to directly affect the middle cerebral artery. And as we'll see in a moment, the middle cerebral artery carries out or supplies very, very important structures in our brain. So if any damage happens to this, we'd have a lot of signs and symptoms, okay? It courses laterally into the lateral sulcus, and so basically, if it's inside, it's going to course laterally, and it's going to come up the lateral side of the brain and supply the lateral side of the brain, okay? Which is the frontal lobe, the parietal lobe, and the temporal lobe, okay? And then it gives off small branches. These small branches are important with the deeper structures in our brain, which are the lateral lenticulostriate branches. These are branches that supply internal capsule and basal ganglia. So again, to reiterate, it's very bad because if there's a stroke in the middle cerebral artery and the internal capsule is affected, for example, it's a whole disaster. Okay? As well as like it supplies all these lobes. It's a disaster. تمام؟ تمام. Now, this is the structure. These are the structures, or this is the area that the middle cerebral artery supplies. Can you guys tell me any important parts of this area that is supplied by the middle cerebral artery? Just like point out any part of the cortex. So we have Broca's area, okay, over here. We have the lateral part of the homunculus, or the lateral part of the primary motor cortex. We have the lateral part of the somatosensory cortex. We have part of the hearing, and we have some of Wernicke's area over here. These, يعني, they're very important structures, and it's a disaster to have a stroke over here. تمام? So yeah. So the areas are affected as we mentioned. Primary motor area, premotor area, Broca, that stuff. And if you remember their functions, it's very easy to remember the clinical significance, or point out the clinical significance that happens with the middle cerebral artery. Okay? So this is a picture from your lecture. It's very important regarding your MCQs, but I just added it for the sake of completion. Now, we go into the anterior cerebral artery. The anterior cerebral artery, again, is one of the branches of the internal carotid. What does it supply? If you guys remember, we mentioned it earlier. It's kind of in the picture as well. The anterior cerebral artery supplies the medial portion of the cortex. So if we're looking at the medial portion over here, it supplies the medial portion. It supplies some of the basal ganglia, but it mainly supplies the medial portion of the cerebrum. If we said middle cerebral artery supplies the lateral portion, the anterior cerebral artery will supply the medial portion. Okay, so based off of this, you would know, and it supplies the medial portion of the homunculus. It would supply part of the corpus callosum. It would supply a big portion of basal ganglia and whatnot. Okay, it's depicted by the yellow over here. Okay, so yeah, basically it courses over the corpus callosum and then it supplies all the areas in here. Okay, so yeah, yep, okay, yeah, it gives out the basal ganglia branches that it gives out. Is the medial lenticular striate branches. So from the middle cerebral artery, it's going to give out the lateral lenticular striate branches, and the anterior is going to give you the medial lenticular striate branches. Okay? Tamam. And again, this is another picture from your slides for the sake of completion. Now we have the anterior and posterior communicating arteries. The anterior communicating artery basically communicates the anterior cerebral arteries together, and the posterior communicating artery communicates the anterior supply with the posterior supply. Okay? And they both have kind of certain things that I need you guys to know. The posterior communicating artery over here supplies the thalamus. It's one of the three supplies of the thalamus. And we got a question last year. It was a picture of the thalamus, and it said or like I think it was like an angiogram or something. And it was asking for the blood supply of the thalamus, and I got it wrong. Okay, this is very important. Okay. Oh yeah, over here you have the posterior cerebral artery or superior cerebral artery. We'll see it in the brainstem. This is the posterior communicating artery. It's one of the branches of the thalamus. Okay, the anterior communicating artery is just one single artery. Okay, which is in between the anterior cerebral communicates between the anterior cerebral arteries, and it is the most common place for aneurysms. If an aneurysm happens here, what would غير الbilateral heminopia that I've mentioned here, what hematoma would I have? If you guys know. I'd have a subarachnoid hemorrhage. Okay, any aneurysm that happens or any basically lesion in the arteries that would cause a hematoma in the circle of Willis, it would be subarachnoid hemorrhage. Okay, تمام. This is just a summary of like the different arteries and what they supply. عشان it's just simpler, and then you guys can actually know what lesion is associated with what. Okay. Now for the clinical part, again, that has to do with the blood supply. We have this image over here, and Ghedaa mentioned this earlier. If you guys can remember, what hematoma is this? And what's affected? Like what artery is affected? This is a epidural hematoma. And how you can know that this is an How you can know this is an epidural hematoma is first it looks like a lemon. وبعدين epi, okay, EPI, just reorganize the words, make it pie, lemon pie. I don't know, it's just like something to make it easier for you guys, okay? Epidural hematoma. Epidural hematoma would mean it's a ruptured middle meningeal artery, okay? Going into our second one over here, which is what type of hematoma is this? It's a subdural hematoma. Okay, the subdural hematoma exactly, it's ruptured bridging of the veins. Okay, so what I mean by bridging of the veins is the confluence of sinuses I talked about earlier. If anything happens to these veins, it would be subdural, which makes sense because we said in the veins run in the layers, the two layers of the dura. So subdural hematoma, and it also looks like a banana. So B for banana, sub B. If you make the link BB, okay? Okay. Now, this over here is something I just mentioned. What is this hematoma? This is subarachnoid. Yep, subarachnoid hemorrhage. The subarachnoid hemorrhage is due to any aneurysm or rupture of any aneurysm in the circle of Willis, and it looks like a star. If you, I don't know if you can see the star. Sometimes, yeah, berry aneurysms, very important. But yeah, so this is how you can memorize these like hematomas and stuff like that. Okay. Now let's look into some histology. This is pretty easy because it kind of is similar to the spinal cord. We have 6 cerebral layers. You don't need to know anything more than that, by the way. You have 6 layers in the cerebral cortex. I think you just need to know their names. But I don't think you should differentiate them. يعني it's very hard to differentiate, but the main idea is you have 6 layers, okay? Over here is another section of the cerebral cortex, and they stain it with 2 different colors. The reason of these staining is because we know that the outer cortex is gray matter and the inner cortex is white matter. So the blue over here stains the cell bodies. Okay, it stains the first portion of the neuron. Okay, that's why it's mainly blue, and you can kind of see the cell bodies over here. Okay, as we go deeper into the cortex and start to enter the white matter, the axons of those cell bodies are starting to move, and those axons have myelin, which will take up the red stain. So as you go down over here, you start to see more and more red staining because you are seeing the myelin sheaths of those axons. And then you can also see over here some pyramidal cells and whatnot in different layers of the cortex. Okay? Okay. Now again, this is the same exact picture Ghedaa originally put, but I just want to reiterate the fact that cerebrum has pyramidal cells. Pyramidal cells are found in the cerebrum, the spinal cord, the anterior horn of the spinal cord, and yeah, I think that's it. And they basically look like pyramids or teardrop cells, just like Ghedaa said. Okay? My laptop is heating up. Okay. So now we're going to go into seconds really quickly. This is just an image to show you a sagittal view of the brain and to orient yourself على where the sections are to make sense of like what section you're seeing at what level. Okay. In this portion, we're going to go into the cerebrum, and then the next portion we're gonna go into the brainstem. Okay. Here, what do we have over here? What's 29? If you guys know. Okay. So 29 over here is the long association fibers. It's the cerebrum, yeah, بس إنه في long association fibers between gyrus to gyrus, and then we have the short association fibers over here. Okay. I don't think it's that important, but what's important is this one. What would this one be? What's 1A and 1B? We talked about them earlier. The superior sagittal sinuses, exactly. Tamam. Yep, okay. Now we have over here, again, 1A and 1B are superior sagittal sinuses. What is 30, if you guys know? It is the corpus callosum. It's basically the top part of the corpus callosum, okay, called tapetum, I guess. But it is part of the corpus callosum. Tamam. Now let's go deeper. We have again the superior sagittal sinuses. You're going to keep seeing the superior sagittal sinus until you reach the cerebellum, okay? What is this structure over here too? We have another sinus over here. If you remember, what's this? Inferior sagittal sinus. صح, inshallah. Okay, now let's go into deeper structures over here. So what's 32 and 31? The corpus callosum was above. What would this also be? It would be the splenium and the genu of the corpus callosum. The lateral ventricle is 41, or yeah, 38 and 41. I think 41 is the choroid plexus, okay? What's 40 and 39? They're part of the lateral ventricles, but which part exactly of the lateral ventricle? It would be the anterior horn and the posterior horn. Tamam? Yes, exactly. Tamam. Okay. Yeah, I don't think we missed anything. Okay, again, we have the superior sagittal, inferior sagittal, splenium, and genu, or I think splenium genu. Now we're going into the basal ganglia structures. What is, let's go into 50. What's 50? It's the one that's most, exactly, thalamus. طيب, what's 47? 47 is the head of the caudate nucleus, exactly. طيب, what's 48? Lentiform nucleus, and then this would be this little triangle. Internal capsule with its anterior limb, posterior limb, and the genu. What would this portion be? 49. This little area. It would be is it external capsule? I think it's the claustrum. I think, yeah, it is the claustrum. External capsule is not labeled, but it is the white portion in between the lentiform and 49. Tamam? Okay. As you can see over here, you can also see إنه هنا في anterior cerebral artery. It's not very obvious, but if you think of it logically, if we're in the middle or in the medial portion of the brain, it would most likely be the anterior cerebral artery. Okay? Does that make sense to you guys? Okay, تمام. I think we have a couple more sections. Okay. I think these are literally the same sections, except what's 42? I think 42 and 52 are different. What are these structures? They're not really important. 52 would be the pineal gland. What would 42 be? If this is the thalamus and this is a cavity, what's the cavity? No, 42. 42 would be the third ventricle. Okay, it's the starting point of the third ventricle. As we said earlier, in the third, exactly. The third ventricle is associated with the thalamus. Tamam? Tamam. Now let's go over the sections really quickly in an image. We have these two cavities, which are the lateral ventricles. We can also see here the superior sagittal sinuses. This is the frontal lobe, this is the occipital lobe, and here you see the falx cerebri. Remember when I said it goes in between the two cerebral hemispheres? Yeah. So this is the falx cerebri, okay? Again, we see the basal ganglia. We have the 26 would be the head of the caudate, 28 would be the thalamus, 27 would be lentiform, okay? This is the internal capsule, posterior horns, and whatnot, okay? Once you see it on the actual model, the anatomage itself makes so much sense, okay? Again, these are the same structures, okay? I don't know why, by the way, they put the same picture like 10 times when it's the same structures. Now we're going a little bit lower. Again, frontal lobe. But I want you guys to know this part. Okay, 15. What's 15 specifically? These two areas over here, they're sinuses. What is it called? Transverse sinus. And what would this point over here with my arrow be? This one in the middle? It's going transversely, but what's this point in the middle? The confluence of sinuses. Tamam. Over here, we have areas of the brainstem, which does not concern us. We will talk about later. Okay? Now, this is a lower section. So what would 15 here be? 15 would be the sigmoid. In your module, it says transverse sinus, but I believe it's the sigmoid sinus. So you could go over with the module, and you just stick to transverse sinus, but if it's a lower section, it should be the ايش اسمه sigmoid sinus. Because again, you don't see the confluence of sinuses. وبعدين you have one point over here, which should be the occipital sinus. Okay? تمام. Again, okay. Over here, if this is, you said earlier, the sigmoid sinus. What's this sinus that drains into the sigmoid sinus? We said one important vein that drains into the sigmoid sinus. It would be, لا مو great vein. Great vein is into the superior sagittal sinus. This over here is the superior petrosal vein. Okay, superior petrosal vein coming from the cavernous sinus. What's 11? Do you guys know what 11 is? It's close to the structure. 11 is the internal carotid artery. Okay, 20, yeah, internal carotid artery. 23 over here would be the cavernous sinus. Come on. Superior petrosal sinus draining into the transverse sinus. Again, this is the sigmoid sinus. You see it's S shape. Okay. Come on. Now we have a little mini case. Okay, no, I was supposed to say the case. Okay, hold on. So we have this case of a 45-year-old man, and this man is hypertensive, and he drinks alcohol, and he smokes. Okay, he was brought to the ER because he started mumbling over his speech. Okay, as he was mumbling and whatnot, he tripped and fell. And let me tell you some signs and symptoms. He has right facial and arm weakness. He is not able to speak. He has difficulty moving his arm. Basically, he has weaknesses in his right leg as well. Okay. Based off of what I just said, do you guys know what part of the brain is affected? He's mumbling over his speech. That's a big giveaway. And he also has weaknesses. He can't move, and he has weaknesses in his right side of the brain body. Is it A, B, or C, or D? B, which is exactly B. Why did you choose B? Broca's area, exactly. Because he's mumbling over his speech, and he also has right-sided weakness as well as right-sided loss of sensations. It easily is B. Okay. What's the diagnosis specifically? Like, what causes this Broca's aphasia and all these symptoms? In Broca's aphasia, the patient is aware. Yes. What's the diagnosis? Why do you think he has such symptoms? MCA, exactly. MCA, middle cerebral artery stroke. So we know that the middle cerebral artery supplies this portion of the brain, which will exactly give the symptoms. With Broca's aphasia, the gyri over here would be also affected. Okay. Now, point out the middle cerebral artery here if you can. It's not 10. 10 is coming up from over here. Nope. It's number 2. Okay. Number 2. If this is the internal carotid artery, and it becomes continuous with the middle cerebral artery. Okay. Can I just go back for a second? I had an anatomage, but I don't know where it is. Hold on. Okay, I think the anatomage is coming ahead. But yeah, it's number 2. Okay. What are the functional areas? As you guys said, إنه في Broca's area, في primary motor cortex or primary somatosensory cortex. تمام. Now we have another case, which is a 30-year-old woman. She came to the ER because she has right-sided temporal headache. Her eyes are bulging out. 3 days earlier, she had a tooth extraction. She has high temperature. She has ptosis and meiosis. What do you guys think is most likely the clinical cavernous sinus thrombosis? طيب, inshallah, inshallah. Why did you say cavernous sinus thrombosis? Teeth. She had an upper molar tooth extraction, which caused the sinus, the thrombosis. طيب. Give reasons for the following. Why is her eye? Okay, I did not say this, but no, her right eye was deviated medially. Why do you think it was deviated medially? Okay, that's partially right. She had, because of the cavernous sinus, it holds the cranial nerves that are responsible for the eye. Why did she have, okay, she had decreased sensation of her upper right side of the face. Why did she have decreased upper right side of the face? Cranial nerve 5, inshallah. And then, why did she have bulging of her eyes? She had bulging of the eyes because of the increased intracranial pressure that happened. I think so. I think that word, yes. Ophthalmoplegia, I'm guessing. But إنه she had increased pressure within, because the cavernous sinus is right behind the eyes as well. It increases the pressure within the eye. تمام? We are finally done with the cerebrum. Does anyone have any questions that have to do with the cerebrum and anything that is with this? Okay, تمام. Let's go really quickly through the brainstem because I don't want to take up super much time. Okay. We're gonna go through the anatomy of the brainstem. Just a quick overview of the brainstem. We know that there's a midbrain, and there's a pons, and there's a medulla. In different areas of the brainstem, we have different cranial nerves that come out of it. This is all brainstem content that you should know like the back of your hands, and as much as this is a lot, it's also very important for your OSPE. They could easily bring you a brainstem question that looks just like this and have or like mark a specific nerve and tell you what this nerve is. So let's quickly go over it from bottom to top. We have the medulla over here. The medulla has the pyramid tracts and it has the olives. Okay, out of the between the olive and the pyramids, we have the anterior lateral sulcus. No, anterior medial sulcus, which takes out, the nerve that comes out of it is the hypoglossal nerve. Okay? Between the olive and the structure behind it, there's the anterior lateral sulcus, and we have 3 nerves coming out of it. We have the glossopharyngeal nerve, the vagus nerve, and the spinal nerve. Okay? So we have 4 main nerves that come out of the medulla itself. Hypoglossal, which is cranial nerve 12, glossopharyngeal, which is cranial nerve 9, vagus, which is cranial nerve 10, and the spinal nerve, which is cranial nerve 11. Okay? This is the gist of it. Okay? Out of the pons, we have other nerves that come out of it. Okay? They come out of the medullopontine segment, basically. Okay? Most medial is the abducens nerve. A little bit more lateral is the facial nerve. And most lateral would be the vestibulocochlear nerve. Okay? This is coming out of the medullopontine region. Out of the actual pons itself, you would have the big trigeminal nerve coming out. Okay? And then when we go up to the midbrain, we have the trochlear nerve, which comes out. It's the only nerve that comes out of the back of the brainstem and circulates basically to the front. And then you have the oculomotor nerve. Okay? Knowing where it comes out of from and knowing what's most medial to most lateral is very important because if anything happens to the blood supply, you know exactly where it is, as well as if a patient comes to you with certain signs and symptoms, if you just do a simple cranial exam, you can localize exactly where the problem is. Okay? This is another picture of the brainstem just in real visuals because I think that's important again. And then here I have just like the cranial nerve functions. Um, يعني in a nicer way, we'll go into them in a little bit. Okay. This is another summary that I made. Initial again, the ophthalmic nerve supplies motor supply and parasympathetic supply. Motor supply to all extraocular muscles except for two muscles, lateral rectus and superior oblique. Parasympathetic to the ciliary muscles of the eye. Okay? If damage happens here, you would have third nerve palsy. The person would have ptosis and their eyes would be deviated laterally. Okay? Because if this is damaged and lateral rectus and superior oblique are not damaged, obviously the eye would tend to go more laterally. Okay? Cochlear nerve, again, it supplies only one extraocular muscle, which is the superior oblique. Damage into that, there would be diplopia. And the most common scenario a person can give you with trochlear nerve damage is they can't go down the stairs because they cannot move their eyes medially. Okay? The trigeminal nerve is a very big nerve. So just to sum it up really quickly, it's the major sensory nerve of the face. Okay? It supplies just all the sensations to your face. And it has three main divisions, which is V1, V2, and V3. V1, which is the ophthalmic, supplies the eyes and the forehead. V2, which is the maxillary, supplies your maxillary area and your upper teeth. Your mandibular region, or your mandibular virgin, supplies the teeth and the chin. Okay? The lower teeth and the chin. Abducens nerve, it supplies one more extraocular muscle, which is the lateral rectus, allows it to move laterally. If there's damage, the eye would be deviated medially. You cannot move it laterally. Okay? And then you have the facial nerve, which is responsible for a lot of things, but majorly your facial expressions, the muscles in your face. Okay? If there's a problem in the facial nerve, you'll have Bell's palsy. Okay, and I'm pretty sure you guys know it. I think it was mentioned so many times. And then you have glossopharyngeal, supplies your pharynx and your larynx. Your vagus, which supplies a bunch of structures from your pharynx to your larynx to your entire GIT up until 2/3 of your large intestine. And then your accessory nerve for shrugging of your shoulders and moving your head side to side, which is the sternocleidomastoid. While hypoglossal nerve supplies the muscles of your tongue. Okay? تمام. Okay. Okay. Let's go into this, which is what's this disease basically? What's the disease and what nerve is affected? This is Bell's palsy, and the nerve affected is exactly cranial nerve 7. Okay, half of their face is basically just completely paralyzed. They cannot move it. Okay. You have this is Justin Bieber, just so you guys can remember it, because he had Bell's palsy. What's this? He has ptosis, and his eyes are deviated laterally. What's this? Cranial nerve 3, which is third nerve palsy. Over here, we have this is third nerve palsy again. What would this be? The eyes are deviated more medial. It's cranial nerve 4 palsy, the trochlear nerve. Okay, they cannot move it like inwards. Okay, and then we have this one, which is the abducens. Okay, the abducens, since they can't move their eyes laterally, their eyes would be more medially. Okay, and this one over here is the what nerve is this? There's deviation of the tongue. Hypoglossal nerve, exactly. Hypoglossal nerve, mashallah, guys. Okay, these are all of the answers يعني. تمام. Now let's go into the blood supply again very quickly. We're going to talk about the posterior supply of the cerebrum. We have the vertebral artery, and Ghedaa mentioned most of it, but we know that the vertebral artery comes out of the subclavian vein. It's going to transverse up through the vertebra and go up into the brainstem, and it's going to give you major branches like the anterior spinal artery, posterior spinal artery, and the posterior inferior cerebellar arteries. In the spinal cord, the anterior and the posterior spinal arteries supply the spinal cord. Okay? Yeah. So did I say okay? It comes out of the subclavian artery. The anterior spinal artery, in terms of the spinal cord, will supply the anterior 2/3, while posterior spinal artery supplies the posterior 1/3. However, in the brain, it is different. Okay, it supplies different structures. Obviously, we have an anterior spinal artery, which supply the medial medulla. Okay, because the vertebral artery, if you can see here, it's over here. It goes up and then it starts dividing. At the portion it starts dividing, we have the medulla over here before it reaches the spinal cord. Okay. So again, it supplies medial medulla. If there is a problem or a stroke that happens in this artery, you'd have something called median medullary syndrome. Anyone know what median medullary syndrome is? Or what signs and symptoms they would have? Okay. 4 M's. Okay. I think that is very true, yeah. So what they would have is what structures are found in the middle, in the medial medulla. You have the hypoglossal nerve, you have the, exactly, motor of the tongue, which is the hypoglossal nerve is going to be affected. Corticospinal tract, which will cause, okay, spastic paralysis. And then there will also be contralateral loss of the sensations, the two-touch discrimination, conscious proprioception, and all that stuff of the body, but not the face. Okay? So whatever structures you find in the middle and the median portion of the medulla, just connect that and يعني, that's going to be the signs and symptoms of the patient. Okay? We have the posterior spinal artery, which again just supplies the posterior 1/3 of the spinal cord. And then we have pica. Pica is going to supply the lateral medulla. Okay? And if lateral medulla affected, what would you have? Lateral medullary syndrome. Does anyone know what the syndrome is? Okay, so it's going to basically cause contralateral loss of pain and temperature because its spinothalamic tract is on the lateral aspects. You would also have ipsilateral loss of facial sensations because the facial يعني not facial sensations, the trigeminal nerve is going to be affected. The trigeminal nucleus is found in the medulla portion. Okay, so you'd have loss of facial sensations. You would also have Horner's syndrome because your sympathetic area is also lateral. You'd also have dysphagia and dysarthria because laterally you have the glossopharyngeal nerve coming up. Okay, as well as the vagus nerve. They both supply the same structures of the pharynx and the larynx. Tamam? Does this make sense? Okay. Nucleus ambiguous as well. Yes. Tamam. Now we go to the basilar artery, which is a very, very important structure, and it's a huge artery. This artery basically is formed because of the joining of the vertebral arteries, and it goes up in the little sulcus that the pons has in the middle. Okay, it's the major arterial supply of the pons. It gives pontine branches over here, and it supplies the medial pons. Okay, it's then gonna give you other branches, which is the ICA, anterior inferior cerebellar arteries, superior cerebellar arteries, and the terminating one, which is the posterior cerebral artery. Okay, let's go into the details of it. Anterior inferior cerebellar artery. It supplies, if we said that the basilar artery itself supplies the medial pons, ICA will supply lateral pons. Okay, if there's a problem بيكون في lateral pontine syndrome. What's lateral pontine syndrome, if you guys know. Lateral hyperacusis because of the vestibulocochlear, and then I think I think that's about it. Most of like I don't think this syndrome is like super important for your OSPE. Loss of facial sensations because of the facial nerve. Exactly. We then have superior cerebellar arteries. Superior cerebellar arteries, it's a little bit full. Okay, it's a little bit higher up. So it supplies part of the midbrain, and it also supplies the cerebellar hemispheres, which concerns the cerebellum part Ghedaa will go over. Okay? Posterior cerebral arteries will supply, or it's basically the terminating branch of the posterior circulation. If there's a problem, بيكون في posterior cerebral artery syndrome. Okay? And it's going to give off thalamus straight branches to the thalamus. Remember when I said the thalamus over here has 3 branches, the posterior communicating and this one, which is the posterior cerebral artery? Remember this. And these are branches of the thalamus. If anything happens in these arteries, there will be basically يعني infarction or ischemia to the thalamus. تمام? Here's the angiogram that I was talking about. Okay, so again, is the circle of Willis and everything about circle of Willis clear? Okay, تمام. Let's label them together. It might be a little complex, but we can go through this together. Okay, let's go from the bottom over here. What's 14? These two structures would be the vertebral arteries. 13. What's 13? 13 would be the basilar artery. What's 6? 6 is pica. صح. Mashallah. What would 12 be? It's the 12 and 15. It's the last branch of the basilar artery. Not superior, it's posterior cerebral artery. Posterior cerebral artery, okay? Yes. Okay. What would 9 be? Very obvious. Internal carotid artery. What would 10 be? 10 and 2. They're both on either side. Middle cerebral artery. What would 8 be? It's like in the middle. Anterior communicating artery. What would 7 be? Anterior cerebral artery. Inshallah. This is all the labelings. This is super important for your OSPE. You should know this, come on. Okay? This is another angiogram picture from your slides. I don't think they would be using this, but I think it is a lot clearer. Okay? This is another big picture of the circle of Willis, just to join them all together. And this is a picture from your slides showing every branch and what they supply. And again, this wouldn't be me if I don't tell you to draw it out. It's literally the best thing to do for active recall. Okay? Let's go into the sections really quickly. Again, to orient yourself. Okay. Okay. Now, Hina is a little bit difficult because you need to actually know which part of the brain you're in. Okay? We're gonna go from top to bottom, from the midbrain to the medulla. Okay? How do you know you're in the upper midbrain? Do you guys know a specific sign that you can look at in the upper midbrain and know you're in the upper midbrain? What's 3? هو true, it's there, but it doesn't tell you, oh, I'm in the upper midbrain. What's in the upper midbrain? هو yeah, optic chiasm could be a sign, but there's another thing specifically they say is the Mickey Mouse sign. I tried to look for this Mickey Mouse sign for so long, by the way, and I think I ended up finding it. These are the ears, and this is the eye, and this is the face. Hina, this is the Mickey Mouse sign. Okay? When I used to do this, I would always think that this part of the brain, which is the vermis of the cerebellum, I think it looks like a bee tail, and I know I'm in the upper midbrain. Okay, so if you see Mickey Mouse sign or bee tail, you're in the upper midbrain. Okay? طيب, let's go to the structures together. What would 1B mean? Or what's 1B? Superior sagittal sinus. What's 3? Inferior sagittal sinus. Okay, let's go into the actual brainstem. What's 55? The ears of the Mickey Mouse. It's the crus cerebri, tegmentum, crus cerebri. It's المفروض crus cerebri. What's 56? If we're in the midbrain, what's black discoloration? The substantia nigra. Okay, exactly. What's 57? 57 would be the red nucleus of the midbrain. What's 43? It's a specific cavity in relation to the midbrain. Central, not central canal. No. Aqueduct of Sylvius. Okay, central canal would be, yeah, it would be in the spinal cord. تمام. This is the optic chiasm, as we said. In front of the optic chiasm, we have the optic nerve coming, and 27 would be the optic tract. Okay, what would 13 be? 13 would be the internal carotid artery. 15 would be the middle cerebral artery. Okay, I think we've mentioned most of it. Come on. Okay, yeah, I think we've mentioned most of it. Tamam. By the way, these sections are super, super important. Like, you'll have at least 3 questions on them in the exam. Okay? Now that we've gone lower, we know that we're no longer upper midbrain. Why? The Mickey Mouse sign is absent, and then the B tail has become not a B tail anymore. Okay? But you still see, like, the structures of the midbrain. You can still see the crus cerebri, and you can still see the substantia nigra, and you can still see the central, I forgot the word, aqueduct of Sylvius, okay? But then you also here see the يعني termination of a specific artery. Do you guys know this singular artery? Did you guys have similar images to these ones? Yes, we had the exact same models last year, but they're very, very important. Okay. 18 would be the basilar artery. Okay. And over here we have the little area, the cavernous sinus area. What would 53 be? I've given you a hint already. Pituitary gland. What would 13 be? 13 would be the internal carotid. No, 13. Internal carotid. 20 is the ophthalmic not ophthalmic artery. Ophthalmic nerve. I thought you said ophthalmic nerve. معلش. 14 would be the, what would 14 be? Yes, ophthalmic nerve. Look. Oh, oculomotor nerve. I'm sorry, guys. Oculomotor nerve. It would be the oculomotor nerve because we're at the level of the eye. Okay? So this would be internal carotid, pituitary gland, and then oculomotor nerve, and then 14 is the cavernous sinus, 18 is the basilar artery. Okay? I'm sorry for the لخبطة, guys. Is it clear? This is the last part of the brainstem, by the way, so just bear with me شوية. Okay. Now we're in the upper pons. How I used to know that I was in the upper pons is that I started seeing a heart. Okay? This is the heart over here. Okay? It's also the area where you see the transverse sinuses start to come up. Okay? How did I differentiate between upper pons and lower pons? The upper pons, its heart is شوية يعني not connected. We'll see in the lower pons, the heart is kind of connected, okay? And then you also start to see this cavitation over here that's a lot bigger than the aqueduct of Sylvius, which is what, if you guys know, we mentioned this before. Fourth ventricle, exactly. And also, the midbrain just doesn't look like a midbrain anymore, okay? It has these transverse fibers, which is the pontine fibers, okay? These are the transverse sinuses. It's literally the only section you'll see a transverse sinus in. Okay, 13 again. What's 13? Internal carotid. What's 18? 18 is the basilar artery. What's 21? 21 is this one is the ophthalmic nerve. Okay. Here we have the ophthalmic nerve. At the level of the pons, we have the ophthalmic nerve. Well, at the level of the pons, we know that the trigeminal nerve arises. So it makes most sense here. Okay? When we're in the midbrain, at the level of the midbrain, we know that the oculomotor arises in the midbrain area. So oculomotor makes sense to be there. Here we have the ophthalmic nerve. Okay? Does this clear out the confusion that happened earlier? Okay, tamam. Now this is the complete heart I was telling you about. Look at the heart here. It's kind of complete, and that's how I know I was in the lower pons. Here, the heart is kind of separated. So that's how I knew I was in the upper pons. Okay? Again, to look at the structures, we have the pons over here. We start to see the peduncles start to connect to the actual cerebellum. And then we have this area over here, kind of to me looks like a frog's face. So again, another sign I was in the pons. What is the structure اللي طالعة over here that's like kind of bulging outwards into the cavity? What's like 62? It's medial and it's a bulge. What would that be? Cranial nerve, not 6. It's another nerve. It would be facial nerve, more specifically the facial colliculus. The facial nerve, it is the most medial, but specifically the bulge itself is the facial colliculus. The facial colliculus has a nucleus, and the facial nerve comes out of that nucleus in a spiral fashion. So when it goes out in the spiral fashion, it creates that bulge. And when it spirals around the abducens nerve. Okay? Does this make sense? Tamam. What would 24 be? It's coming out of the lateral pons. It would be the, exactly, cranial nerve number 8, which is the vestibulocochlear nerve. Okay? Now, what's the sinus over here? Number 9. Not occipital. Number 9. Occipital would be 7. What's number 9 and number 8? Not what's after transverse sinus is sigmoid sinus. The transverse, we've already seen it up here. You see transverse sinus, and then it starts to go down. It starts to go down into these sigmoid sinuses. Okay? Thank you. Okay. Now, did the pons make sense? Tamam. Now let's go into the upper medulla. The upper medulla, to me, it looks like a 4-leaf clover. That's how I know I was in the medulla. Okay? We have this structure over here, number 44. What's the cavitation associated with the upper medulla? The fourth ventricle, exactly. What would 64 be? 60. What's the anterior portion of the medulla that's coming up? It would be the pyramidal tracts, okay? The two pyramids coming up would be 64. What would 65 be? It's not really obvious over here, but it's the decussation area of the pyramids. Okay? Here we're starting to see the formation of the basilar artery. Okay? 13 here is the internal carotid artery. Tamam? What's 23? If we're at the nasal area and all these sinuses, what would 23 be? like at the lower portion of the face. Not cranial, no. Cranial nerve 1 isn't it ophthalmic? I mean olfactory. It would be over here anteriorly. It's over here at the side. If we're at the lower part of the face. No, this is the mandibular division of trigeminal nerve. Okay? If we're at the lower portion of the face and yeah, at the lower jaw, what would make most sense to be running along the same area? Mandibular nerve. Okay? Yes, V3. V5. No, wait. Cranial nerve 5, V3, basically. Yeah. Okay? Yes. Tamam? Okay. 12 over here is the inferior petrosal vein. And we know in the inferior petrosal vein drains into the transverse sinuses. Okay? I think this is the only time you will see an inferior petrosal vein. Try to just memorize where it is. Okay? Lower medulla again, just to point out really quickly, we have in sigmoid sinuses over here. You can see how they've become actual sigmoid sinuses. You can see 45, which is the صارت central canal, and it's about to go down into the spinal cord. Okay? Anatomage. Really quickly, again, we have the cerebellum over here. We have the occipital lobe. And here we have the Mickey Mouse sign. It kind of looks like a dog over here, but the Mickey Mouse sign. The eyes would be the red nucleus. And 39 would be substantia nigra. Okay? 6 is the midbrain, obviously. Okay? Here, again, we're seeing, what's this? What's 19? If you guys know. It would be the confluence of sinuses. It's in the middle. Oh, I think it's like the starting portion of the confluence of sinuses, okay? Because then the next section looks like this, which we know these are the transverse sinuses coming into the confluence of sinuses. 11, what would 11 be over here? Eleven would be internal carotid artery, okay? 39 again is the substantia nigra. 6 is the midbrain, okay? Okay, yeah, I think it's basically the same thing, okay? 15 transverse sinus, 14 basilar artery, 11 is the internal carotid artery, okay? Now, what would 15 here be? It would be the sigmoid sinus, but in your module, مكتوبة transverse sinus. It should be the sigmoid sinus, but go with your module, transverse sinus, okay? If you guys can ask a doctor about this, by the way, it would be best, because I do believe these are the sigmoid sinuses. But according to your module, it's the transverse sinus, okay? Now, again, 15 and 19. Right over here, 19 is not mentioned. I think it's in the next slide. But 15, again, it says it's the transverse sinus. 14 is the basilar. 11 and 12. Okay, 11 is the internal carotid artery. And 12 was mentioned to be the internal jugular vein, which again, I just believe it's another internal carotid artery, but memorize to how your module says, okay? What's this nerve coming out over here from the sides of the pons? Exactly, vestibulocochlear nerve. Tamam. Again, it's literally the same things over and over again. 19 says that it's a transverse sinus. I think it's the occipital, but go with your module. 15 is the transverse sinus again. Literally everything is repeated. Everything is repeated. Okay. Now here it says 15. Where's 15? Okay, I don't know where it says 15, but okay, هنا صارت sigmoid sinus. Okay. Yeah, it just says here solid sigmoid sinus, and that's about it. Which, if you look at it from before, it's literally the same thing. Yeah, I think you guys should ask anatomist doctors what it is, but generally, they wouldn't give you an anatomic picture and ask you for something that is unclear. Okay? Because last year, حتى our doctors used to be very confused with what sinus is what and what structure is what, because it's very confusing to know on an anatomy. But if they were to ask you, they'd probably ask you like the basilar artery. It's very obvious, the basilar artery is right there and it's distinguishable from the rest. Or the internal carotid arteries. If they would like to ask you intricate details, they would ask you on the model. That's why I say the model is a lot more important. Okay? Okay, out of this, what's this big nerve? Over here. Trigeminal, exactly. It's the biggest nerve out of all of them. Okay? Okay. I think that's it for like the actual brainstem. Now we're gonna go into little cases. We have only 2 cases. We have a 55-year-old woman who came to the neuro clinic. She has difficulty walking, drooping of the corner of her mouth. She has dizzy spells and tinnitus, painful sensation and numbness in her right face. Okay? What area do you think is affected in the brain? In the brainstem. Cerebellopontine, okay, cerebellopontine angle, but more specifically lateral, medial, where exactly? Lateral, exactly, inshallah. Now can you tell me what structures are involved and specify the abnormality? Cranial, okay. Cranial nerve 7 and cranial nerve 8. What's associated with 7 and what's associated with 8? Drooping would be 7. Okay. And dizzy spells with tinnitus would be 8. Exactly. Tamam. And then, okay. And then the facial numbness would be because of the spinal trigeminal nucleus. What's the most likely diagnosis? As you said earlier, the cerebellopontine angle, they would be probably like a tumor or something there. Okay. We are finally done with the cerebrum and the brainstem. Do you have any questions? بدها part 2 والله شكلها. هو we have the cerebellum left, physiolab, and microlab. Do you guys have any questions? Tamam, perfect. Do you want a 5-minute break?
Okay. Now, starting with the cerebellum. In the cerebellum, we're going to be talking about the anatomy. Under the anatomy of the cerebellum, the arterial blood supply and venous drainage, and lastly, the clinical, any clinical relevance to the cerebellum. First thing is just a little recap. As Reem mentioned earlier, the cerebellum, it comes from the metencephalon, and that's the only thing you need to remember in this. Regarding the relations of the cerebellum and what it actually is, where it can be found, it is found also directly below the occipital lobe, as you can see here, and it's separated from the cerebrum by the tentorian cerebellum. It's posterior to the pons as well. It lies posterior to the pons, and the only thing separating the two of them is the fourth ventricle. It also has, as you can see here as well, the fourth ventricle lies between the cerebellum and the pons. There are 2 fissures that can be found in the cerebellum. The primary fissure over here, it separates the anterior lobe from the posterior lobe, and the posterior lateral fissure, which separates the posterior lobe from the auriculonodular lobe. Okay. The cerebellum is also titled the little brain, and it has 2 hemispheres connected by a vermis, and this vermis will be much easily visualized in the upcoming slides. It has gray matter on the outside and white matter on the inside. This will be more clearly seen in the histology section, inshallah. Lastly, the main point that we need to identify that is a difference between cerebrum and cerebellum is the fact that any grooves that are seen on the cerebellum are called fossae and not gyri. In the cerebrum, you can see that these folds create these structures that are called the gyri. However, in the cerebrum, the folds are different. So they have a different name as well, and it's called the fossae. Okay? Now, moving on. Once we look at the cerebellum in different views, it gives us different visualizations. And the cerebellum, the way it looks in a picture like this, for example, in in the normal anatomy, looks deceiving. For example, the superior view for the cerebellum looks like this. As you can see, there's a vermis. The sorry, the primary fissure, which separates the anterior lobe from the posterior lobe, anterior lobe from the posterior lobe, and the horizontal. The vermis, the primary fissure, and the horizontal fissure. That's it. The two, it also has the two hemispheres, this hemisphere and this hemisphere. The vermis basically connects the both of them, the right and the left. Okay. Another view for the cerebellum, the anterior view, which is basically you're looking at it from the side. You can see the three lobes. You have the anterior view, the posterior view, the anterior lobe, posterior lobe, and the foracilonodular lobe. And in this view, the peduncles are very clearly shown. You have the superior cerebellar peduncle, the middle cerebellar peduncle, and the inferior cerebellar peduncle. Inferior, middle, superior. Okay. The inferior is the biggest one. And that's it for these views of the cerebellum. One way I found, because of the fact that we have three peduncles, one way I found to understand how to memorize the wave of fibers that go through the peduncles is using the mnemonic MIA. M and I refers to the middle and inferior peduncles, and these two peduncles always have afferent fibers running through them. So M, middle, I, inferior, middle and inferior peduncle always have afferent fibers running through them. The superior is mostly afferent. However, it's afferent in only one case, in the feedback cycle of one of the tracts. Okay. Does anyone remember the name of the tract? It's fine. It's fine. You guys don't need to remember it. Anyways, when the cerebellum gets opened up or rolled up, the main thing that we need to keep in mind when it looks like this is the fact that the cerebellum generally has a rule of three. Okay, it has three lobes, three peduncles, three functional areas, three deep nuclei, and three cellular layers. Okay, so let's see that in action. As we said, it has three lobes: anterior lobe, posterior lobe, and ventricular lobe. It can be easily seen in this picture as it gets laid out or rolled up, unrolled. Yeah. The primary fissure separates the anterior lobe from the posterior lobe, and the posterior lateral fissure separates the posterior lobe from the folliculonodular lobe. Okay. It also has three peduncles, as we discussed earlier, and three tracts. One of these tracts is the spinocerebellum. Another one is the cerebrocerebellum. The spinocerebellum is the one that is found most medially, and the cerebrocerebellum is found on the hemispheres, on the lateral hemispheres. There is also one last tract, folliculonodular, and it's found over here in the folliculus and nodulus. It's here. It's right here. Okay. Now, as I mentioned before, there are three deep nuclei in the cerebellum. You have the dentate nucleus, the interbose nucleus, and the fastigial nucleus. The fastigial nucleus is the the innermost nucleus in the cerebellum, And the dentate nucleus is the most found most laterally. And we're going to get into the function of each of them. This is just a general map. And in this matter, or yani in the context of the deep nuclei, the most important one that you need to keep in mind whenever you are thinking of the OSPE is the dentate nucleus, because they're always going to ask you about it. It's the most lateral one, and it's the one that is related to any motor planning, anything that requires learned skill. Okay. As I mentioned before, there are three cellular layers. The molecular layer is the innermost, and the granular cell layer is the outermost layer. The granular cell layer gives signals to the pregnancy cell layer, and the pregnancy cell layer gives signals to the deep nuclei that we just discussed. And then the molecular layer just kind of takes these signals and amplifies them. Okay. This is just a quick summary, because I'm not going to go into every single tract and every single input in regards to the cerebellum. That would take quite a lot of time. However, just to keep the flow of thought as one, we have the middle cerebral peduncle and inferior cerebral peduncle. As we said, these two are always afferent. So for the middle cerebral peduncle, it receives input from the contralateral cortex, and it goes into the cerebellum. The inferior cerebral peduncle gets input from the spinal cord, specifically for proprioceptive information. And the superior cerebral peduncle gives out signals from the cerebellum into the contralateral cortex. That's it in a nutshell. Okay. And lastly, this is a summary table that discusses the clinical notes as well as the tract, the function of the tract, the lobe associated with the tract, any deep nuclei that is related to the tract, how the peduncles play a role in the transmission of this tract, and if it's damaged, or if this tract is damaged in any way, shape, or form along any of these key players. This is the presentation that you would have. So if the dentothalamic tract gets damaged, you have dysmetria, intention tremors, and I'm sorry, it's a very hard word. Dysdiadochokinesia. Yes. Okay. So if a question said name two connections of the dentate nucleus, what would the answer be? You would have, if the question said name two connections to the dentate nucleus, you can say the thalamus, the ventrolateral nuclei in the thalamus. You can say primary motor cortex is also correct, because it does take it. The primary motor cortex is also there. You can also there's a third one as well. I forgot about it. But we can. And there are the main two connections. Primary motor cortex and the thalamus is correct. Okay. So yeah. Does that answer your question? Okay. If the spinocerebellar tract were to be affected, the main presentation would be ataxia in the case of alcohol, or truncal ataxia if the vermis was affected, because as we saw before, the vermis is mostly associated with the trunk, as you can see here. It's mostly associated with the trunk. For anything that affects the spinocerebellar tract, which is found in the middle, truncal ataxia would be the presentation. Okay, and it's mostly seen in medulloblastoma. Lastly, folliculonodular. This was discussed previously with Reem. But anything that affects something that takes part in balancing the body or the eye movements ultimately leads to presentation or clinical presentation of nystagmus and vertigo. Okay, and this is because the MLF and the vestibulospinal tract are involved. Okay, That's the cerebellum in a nutshell. Okay, no need to go into too much details when it comes to the OSPE material for the cerebellum. Let's just keep these points in mind, and inshallah the questions will be very easy to answer. Now, on to some just quick recall pictures from your slides, from your lab slides. We have, can anyone point out what the purple structure would be? Okay, the purple structure would be the posterior lobe. Okay. I think I have a picture here that would show you. Yes. So, the red structure here would be the anterior lobe. In the middle, there's the vermis. And lastly, the pink structure here would be the follicular nodular. Okay. When you look at the purple structure, as I said, it's the posterior lobe. You can kind of imagine it because, as I said, the shape of the cerebellum is deceiving, especially when it actually looks like this, all rolled up and stuff. So, just try to imagine it. At the top, there's the anterior lobe, the one in green, and then you have the one in brown, which is the posterior lobe. It would be the one in purple, which is taking up the bulk of the cerebellum. Okay, in the middle is the vermis, of course. And then it's not shown here, but the follicular nodular lobe would be tucked in on the other side, as we saw previously in the other picture. Okay, so in here it's untucked. Okay, I hope that made sense. Another picture that we can very quickly go through and identify. As I mentioned before, the bulk of the cerebellum is taken up by the posterior lobe. So the blue part would be posterior lobe. Okay. The one in the middle would be the midbrain. We don't need to be able to identify it. Just relation, in terms of relation, just know when this is the midbrain. And lastly, this little vessel over here would be the basilar artery. Okay. Because it plays a direct role in supplying the cerebellum. Okay. Now, on to blood supply. Arterial supply, really quickly. You have 3 arteries. All of them come from the basilar artery. Okay. Branches of the basilar artery. And then posterior inferior cerebellar artery comes from the vertebral artery. Okay. Memorize these, very easy. Can be a question anywhere in the OSPE. Okay. This is how it looks like. Tamam. The basilar artery gives out this one. It gives out the superior cerebellar and the anterior cerebellar. The posterior cerebellar is a branch of the vertebral arteries. Okay. Now, onto the venous drainage. We have 2 main veins that drain the cerebellum. You have the superior cerebellar vein and the inferior cerebellar vein. Both of them drain into the superior petrosal, transverse, and straight dural venous sinuses. These venous sinuses were previously mentioned or explained by Reem. And I think you guys have a clear idea of how they work. Now, this I'm going to jump through because a lot of it was previously talked about by Reem. However, we're just going to talk about the cerebellar portions, okay? Here, in this one, you have, starting with orienting ourselves, this is the posterior part, this is the anterior part. Alhamdulillah. Okay. 15 and 10 are the main ones that we're going to need to identify in terms of talking about the cerebellum, okay? So what would 15 be in this case? That's fine. Yeah, it's the vermis, okay? The vermis of the cerebellum. And then 10 is the posterior cerebellar artery, okay? Just memorize that because it plays a major role in applying the cerebellum, okay? Moving on to the lower midbrain, 10 and 11. 10 would be the vermis again, and 11 would be the cerebellar hemisphere, okay? These are the 2 most important ones in terms of the cerebellum, okay? Next one, upper pons. Now, 9 and 10, again, are the most important ones here, but you also need to be able to identify what 2 is. 2 is the basilar artery. obviously, because it comes in anterior to the pons, right here, and the sinuses over here. You have the transverse sinuses from the right and left side, and then you have the confluence of sinuses posterior to the cerebellum. Okay, 9 would be the vermis, 10 would be cerebellar hemisphere. Okay. Okay. Then we have number 2 over here, basilar artery. Number 4, you have, where is it? Okay, number 4 over here. Number 9 would be the dentate nucleus. Very, very important for you guys to identify. Number 10 would be the vermis. Number 12 would be the cerebellar hemisphere. And that's all you guys need to identify. Okay. In this section. Okay. Facial calculus is related to the pons. Just know a note, it punches out like this. Okay. Okay. Oh yeah, it is number 4 is cranial nerve 5-2. Yeah. Vestibular cochlear nerve, actually. Yeah, it is. I'm sorry. Okay. Upper medulla. You have number 6, which is the 4th ventricle. The cerebellar hemispheres, and generally the basilar artery just going back and forth. Yeah, nothing new here. Dentate is 7. Yeah, the dentate nucleus. Okay. As I said, very important for you guys to identify. Lastly, the most important thing here is the sinuses, but this was previously discussed by Reem, so I'm not going to go over them. Just make sure you memorize them really well, okay? The flow of them, how they go through the sections, and how they kind of join together, important, okay? Now, sections on anatomy, a lot of them were previously discussed by Reem, but I'm just going to go over the cerebellum portion. 10 over here would be the cerebellum, okay? The hemisphere, cerebellar hemisphere, okay? And then you have, again, 10 over here, cerebellar hemisphere, and 19, which is the confluence of sinuses. Okay. 16 in the middle would be the vermis, and then you have 10 cerebellar hemisphere. 15 would be the transverse sinus. That's all you need to memorize for the cerebellum portion. Okay. Cerebellar hemisphere again. Again, sinuses, superior transverse sinuses, and superior petrosal sinus. Okay. Then you have again cerebellar hemispheres. Just make sure you know how to identify them. And number 14 would be the basilar artery. No, and no, it's in front of the pons. There will be a question on this, almost like 80%. Okay. Last anatomy image is these two. You have 41 over here. What would 41 be? The dentate nucleus. It's super important for you guys to be able to identify it. Okay. And then you have 14 on both pictures, the basal artery, very important. 17 is, I think, the fourth ventricle. 16 is the vermis, and 17, yeah, fourth ventricle. Then 19 is the confluence of sinuses. 15 is the transverse sinus, and so on and so forth. You guys are, mashallah, pros at this point. Histology of the cerebellum, very simple, very easy, inshallah. You have, as I mentioned before, white matter and gray matter, similar to how it's organized in the cerebellum. So white matter would be on the outside, on the inside, and gray matter on the outside. Okay. Did I mix them up? Those are gray matter on the outside and white matter on the inside. Yeah. I was right. Okay. تمام. On the gray, in the section of the gray matter, you have the molecular layers that we talked, the cellular layers that we talked about for the cerebellum. Okay. we have three cellular layers. We have the molecular layer, the granular layer, and the um, granular layer, molecular layer, and the, what is it called? Purkinje layer. Yes, it's in here, the Purkinje layer. Okay? Molecular layer, granular layer, and Purkinje layer. Yes, it's right here. The molecular layer, Purkinje layer, and granular layer. Yes. Okay. I'm sorry. This has been a long session. Anyways, so in order, as we mentioned before, granular layer is the innermost, Purkinje layer is in the middle, and molecular layer is the outermost. Okay. See the pia mater, coming in at here, at this area, and in here is the white matter. Tamam? Did that clear any confusion that might have happened? Okay. Okay. Then you have in the cerebellar cortex. Tamam. In the cerebellar cortex, as you mentioned before at the very beginning, part of, yes, Purkinje fibers. These fibers are multipolar neurons that, yeah, Purkinje neurons. Yeah. These are found in the cerebellar cortex and they transmit information into the deep nuclei. Okay, all clear? Come on. This is it in another view as in the silver stain. Okay. You have here the bodies, dendrites going in to the molecular layer, and yeah, just make sure you know how to identify them. That's it for the cerebellum. Before we go into the practice questions, does anyone have any questions for anything that they need to review or go back to? Okay, okay. Now, starting with a question over here. All of these are OSPE questions from previous year. Which group of neurons mask A, B, C is involved in this case of polymyositis? A. Why would you say it's A? Because it's the anterior horn, exactly. As we mentioned before, this can be شوية tricky. However, well, what happens in polymyositis? What occurs? Okay, exactly. The poliovirus infects the anterior horn, and this leads to representation. Exactly. Now, a patient presented with dropped face on the right injured nerve. The injured nerve leaves the skull from which of the following foramen? What would B be? Internal acoustic meatus, exactly. And what other nerve leaves with what would that nerve be also? Yeah, it's facial nerve 7 along with facial nerve 8, vestibulocochlear and the facial nerve. Both of them, they leave through this this foramen. And if the patient presented with tinnitus, the nerve affected would be facial nerve number 8. So that's it. Yeah. Now we have these two images. Okay. What would X be? Or it's the same marked structure over here, the dentate nucleus. And this is why I emphasized on it so much in, when I was explaining. Name two connections that are related to the structure. You guys previously answered this before. The thalamus and the primary motor cortex, and then give one function to the structure. Oops. Yeah. Give one function to the structure. Motor planning is, yeah, one of them. Learning and performing skillful movements. So technically you are correct. Motor planning is another way to say this. Good job, guys. Inshallah. Next question. This is the infamous picture I was telling you guys about. Name this tissue and give two identification points. This is the peripheral nerve, okay? Any two identification points for it? What would tell you this is the peripheral nerve? Yes, epineuron surrounding the entire nerve and the perineuron surrounding the fascicles. Exactly, inshallah. Also the fact that there are myelin, but you can't exactly see the myelin in this picture. this was one of the answers given. Okay. MashaAllah. Tamam. Which one of the labeled cells A, B, C, D is responsible for the secondary motor function of the body? The secondary. C, exactly. And what is C? Purkinje fibers, exactly. Tamam. During lumbar puncture, which layer is most resistant? We kind of emphasized on this a little bit. No. B is fascia. Yes, C. It would be C. And it would be, what's it called? What is that layer called? No. It's called ligamentum flavum. The area that we want to reach is the subarachnoid space. The area that ultimately the needle ends up in order to collect CSF is a subarachnoid space. However, number C is called ligamentum flavum. And here is a review picture. As we mentioned before, the supraspinatus ligament is outside, and then intraspinal ligament is inside, and then the ligament that we are most concerned with in this picture is number C, which is ligamentum flavum. Okay? Make sense? Okay, come on. Next question. A 44-year-old lady presented with a 5-year history of lumbar back pain presented to the emergency department with severe sharp back pain now radiating to both her buttocks. She also complained of urinary incontinence. On examination, motor strength of her left leg was decreased to 3 out of 5, and a digital rectal examination revealed a loss of sensation in the perianal area with a reduced anal tone. Which of the marked areas, A, B, C, D, would be affected in this case? And what would C be? Kodak coin. Okay, mashallah, amazing guys. Yes. Next question. Name the marked structure by the red star, anterior horn, and name what clinical condition that involves it. Poliomyelitis, exactly. So, or ALS is another is another condition. Okay. Now, name the glial cells shown. I didn't include this as a picture. However, ependymal cells, mashallah. And name its function. CSF collection or secretion. Okay. Um, name the circled area in this picture. Okay. And the function? Exactly. Yeah. Specifically substantia gelatinosa or dorsal horn. Still correct. Synapse, second order neuron for sensory, basically. Sensory stuff. Okay. Good. Inshallah. On sensory examination of the patient, there is loss of pain, temperature, sensation in the right lower limb. Which of the following labeled tracts is provided in the spinal cord section that transmits pain and temperature, according to this patient? Okay, on which side? Is it the right side or the left side? The left side, exactly. And mention two arteries that supply the structure. Exactly. Okay. So you said F. What would another structure be other than F? D. Yes, exactly. Because they're technically anterior and the lateral versions of the same tract. However, the anterior tract, which is F, is a minor tract, not the main tract. The main tract is the lateral spinothalamic. Okay? So keep that in mind. Usually when they're asking you about temperature and pain, they're asking about the lateral spinothalamic tract more than the anterior one. Okay, تمام. Anterior and posterior and arteries. Identify the circle structure. This is a longitudinal section. Node and vermier. And what is its function? Saltatory conduction. Exactly. Of action potential. Yes. 50-year-old alcoholic patient presented to the clinic with broad-based gait. He was swaying from side to side. Nystagmus and vertigo were also present. Which of these labeled lobes were involved in this case? B. Exactly. And what is B? The vermis. And this is why they the patient was swaying from side to side. Anterior vermis syndrome. Exactly. Now we kind of just quick question because we kind of answered something like this before. B. What is B? Pyramidal cells. Primary motor function. This is not. Yeah. Yeah. Exactly. Yeah. Mashallah. Okay. So now going into the next question. This is pyramidal cells in the cerebrum. In the cerebrum. A 45-year-old hypertensive patient presents with cold, sudden freezing, painful sensations in her left arm. In addition, she also complains of weakness and numbness down her whole left side. When examined locally, she was weak and numb on the left side with chorea on the left arm. Which structure is affected in this case? Thalamic pain syndrome. This is D. MashaAllah, guys. MashaAllah. Okay. Now, you have this picture. Name the structure circled in lead. What would that be? Broca's area. Okay. It's wrong. It's not Broca. Yes, Wernicke. Yes, Wernicke's area. Broca's area is more anterior, if you remember, because it's related to the motor kind of speech. So it would be more anterior. This is more related to the temporal lobe and stuff and the parietal lobe. So this would mean it's Wernicke's area. So that's it. Yeah. What are the neurological manifestations resulted from a stroke to this area? Wernicke's aphasia, another name for it is receptive aphasia. Okay. All clear? Okay. A patient has dysphagia and dysarthria. Which nerve is affected in this case? Out of these, A, B, C. A, exactly. And what is the arterial supply to that area? Pica, exactly, mashallah. Now, name the marked structure over here. The thalamus, exactly. And what are two sources that supply the marked structure, or arterial sources? It is correct, mashallah. That is correct. It's usually not named like that. That's why I paused. تمام, mashallah. Posterior communicating artery and posterior cerebellar artery. تمام. تمام. Which of the following is due to oculomotor nerve damage? A. And what is A? It's okay then. Exactly. A third cranial nerve palsy. Okay. Point out the MCA and mention one branch for it out of these. B. And one branch. You have anterior corridor. Another main branch. Anterior corridor is not correct. There's a big branch that comes out of it, the MCA. It supplies the thalamus. Lateral reticular striate. It's not big, but it's the main one. out of the MCA. Okay? Make sense? Okay. Come on. Identify structures A and B. Don't look at it. خلاص, it's there. Okay, yeah, for A is the fourth ventricle, and B is the aqueduct of Sylvius. Okay? And now another histology question. Name the marked cell. It's a multipolar neuron, and any two locations where this cell is found. Exactly, mashallah. Next question. You have a 45-year-old patient presenting with a history of difficulty in swallowing. On examination, there is also loss of taste sensation in the posterior 1/3 of the tongue. Which of the following labeled nerves is affected in this case? No. Because, yeah, exactly, it's B. What is B? It's not number 10. Glossopharyngeal nerve. Exactly. C is vagus. Exactly. Number 10, yeah. Okay. Tamam. Name structures 1, 2, 3, and 4. What would they be? Lateral ventricle. Okay. Lentiform nucleus. Genioventricular capsule. And then lastly is the caudate nucleus of, yeah, not exactly the thalamus, the caudate nucleus. Okay. Tamam. Marked with a black arrow. One clinical manifestation that results from damage to the marked structure. And this is something that Reem emphasized on. No, it's a big nerve. Exactly. Coming out of, it's nerve number 5. And what is one clinical manifestation? Okay. What is one clinical manifestation that results from the damage to the marked structure? Loss of facial sensation. Exactly. تمام. Occlusion of which of the following vessels would result in loss of sensation and motor function in the lower limb? C. What is C? Anterior cerebral artery. Cerebral artery. Okay. Now we have a baby. With congenital hydrocephalus, a CT after birth reveals marked enlargement of the lateral and third ventricles and a small fourth ventricle. Which of the following structures would be obstructed in this case? Exactly. It's E, the cerebral aqueduct of Sylvius. Okay. Now, checkpoint before we move on to microbiology and physiology, because now we're done with the anatomy section of this. Does anyone have any questions at all? About anything related to anatomy that you need to review or go over again? Yeah, it's understandable, صراحة. There's a lot of concepts related to neuro. However, me and Reem mentioned this more than once. If you repeat the same piece of information as just either by drawing or anything that involves you speaking stuff out loud, it would help, inshallah. Exactly. التكرار يعلم الشطار. You guys got this, inshallah. Anyways, any questions before we move over to microbiology and physiology? Very easy sections, inshallah. Alhamdulillah. Now Reem will take over, inshallah, with physiology and microbiology, and that will be the end of our little review.
Okay, so now let's get into the easiest part of the session, which is the physio lab, and then following it would be the micro lab. I'm gonna just give you the gist of things because most of the things are kind of technical and you have to actually do it in the lab. So I'm gonna just give you like the gist of what you guys actually do in the lab and then follow it up with what you need to know in the OSPE, okay? You guys have two physio labs, which is the nerve conduction test, and then we're gonna go into the EEG. Okay. What's the nerve conduction test? Or in other terms, it's called an EMG, I believe. It's basically just a test to assess the actual electrical impulses going down the nerve pathway you want to assess, okay? And this specific nerve could differ from person to person, from the age, from the gender, how myelinated that axon is and whatnot. So if you test a nerve that is unmyelinated versus a nerve that is myelinated, the unmyelinated nerve's electrical impulses would go down a lot slower than the myelinated nerve. Yeah. Okay. And when do we usually do this test? We usually use it for diagnosing certain neuropathies, specifically the demyelinating diseases. So it could be used for multiple sclerosis. It could be used for GPS, for example, all that stuff. Okay. And obviously, if you guys know from your physio lectures, the more myelinated the axon is, the faster the conduction is. Okay. This image here, I don't think it's important at all, but it just shows you a normal electrical impulse versus other neuropathies and myopathies. Okay. You can see that the normal impulse you see it's very high amplitude and very high frequency. Okay. Now we have two methods that we can do a nerve conduction test that was listed in your module. We have a direct needle electrode stimulation and we have the surface electrical stimulation. The direct needle stimulation is quite literally puncturing the nerve. Okay, you put the needle into the nerve itself. It's going to be more accurate and more precise, but as you can imagine, it's very painful and it risks nerve damage. So we don't use it at all. Okay. In comparison to the surface electrical stimulation, which is actually what you used in your lab, you just place the electrodes over the surface of the skin and collect the electrical impulses that are transmitted into the skin. Okay, so we just send out the stimulus and then we assess the nerve and its depolarizing factors and whatnot, assess the action potential of the muscle itself. Oh, but that's basically it. And it's a lot more invasive, a lot less invasive, and it's used for, obviously, as we said, certain things that affect nerves, demyelinating diseases, also in like carpal tunnel syndrome or ulnar nerve problems. Okay. Now, let's see what this test actually does. This is what you guys did in the lab itself. You place electrodes on your thenar or hypothenar muscles, and then you tested the nerve associated with these muscles. For the sake of this discussion, we're going to be testing out the ulnar nerve, okay? Meaning that we're testing or we're looking at the hypothenar muscles as the stimulus or the contraction, Type. I want you to focus with me on this one specifically. We are going to place two electrodes on the pathway of the ulnar nerve. One electrode up here and one electrode down here, okay? This electrode up here is labeled S2, and this electrode down here is labeled S1, okay? We're going to be sending a stimulus down S2. As you can imagine, logically speaking, this electrode is placed on a further point of the ulnar nerve, meaning that when I send down the stimulus from here, it's going to take a longer time to reach the muscle and cause an action potential. Okay? In computer terms, what would the computer show you? It's going to show you this. It's going to show you, if this is where you started the stimulus, it's going to take a while before it causes an action potential. Okay? This is called, from S2 to the muscle itself, that is called proximal latency. Okay? When we stimulate S1, what we're going to see is a shorter time to reach the muscle, obviously, to cause an action potential. So if you started the stimulus here, you can see that the action potential happens immediately. This electrode, the stimulus from this electrode to the muscle is called distal latency, okay? Now, to not get confused like I got confused, I was like, why is this distal and why is this proximal if this one is more proximal to the muscle and this is more distal to the muscle? It's basically this electrode is more proximal to the body itself, and this electrode is more distal to the body itself. Okay? Okay. So from this electrode to the muscle, proximal latency. From this electrode to the muscle, it is distal latency. Okay? Okay. Now, why is this significant? Is because we will take the difference between the latencies. So I'm going to calculate S2 to the muscle and S1 to the muscle and subtract them from each other. Okay? That's going to give me the difference between the latencies. Okay, tamam. Now we're going to measure the physical distance between the two electrodes. Okay? That is the difference between the stimulation sites. Why is that important to me? Is because they'll ask you to calculate the conduction velocity. What's the conduction velocity? It's literally the distance over time. Okay? Distance of what? Distance of the stimulation sites over the difference between the latencies, the time difference between the latencies. Okay? And we're going to go over a practice question later. Okay, is this point clear? I'm hoping this point is clear. Tamam. Okay, now let's go over. Okay, now let's go over EEG. The EEG, what it is basically we are wanting to figure out the electrical stimuli in the brain. Okay, the actual brain waves itself, the actual impulses that happens in the brain and everything. Okay, the difference between an EEG and an EMG, or the nerve conduction test that we did, is that the EEG does not assess action potential. We're not looking for contractions of muscles. We are testing, or we are seeing the summation of electrical impulses between the dendrites. Okay? So an EMG, or a nerve conduction test, assesses action potentials, while an EEG is a measure of the summation of the dendritic postsynaptic potentials. Okay? The EEG is usually there to diagnose certain things like epilepsies, because in an epilepsy, if you guys remember from your Dr. Abdul Ahad lecture, an epilepsy is just a big, big, big brainwave of energy. And you can see that on an EEG. And then brain death, obviously, if the brain is not functional, you will not see anything on an EEG. Okay? Now, this EEG could be affected by different things, like the state of arousal of the cerebral cortex. Are you awake? Are you sleepy? Do you feel hungry? Are you thinking, etc.? Okay, different stages of sleep, and we will go into that in a little bit. External environment, meaning that, I can't just if I'm in a room and I have an EEG on, if someone talks and if I hear something, that's gonna stimulate my brain in some sort of way that you can see. If I smell something that's yummy, for example, that's going to affect the EEG. Okay? Okay. Now, there's two versions of the EEGs that was shown in your modules. There's this one, and then there is this one. I'm going to speak about this one because it's important in the OSPE, even though that's not what you did in the lab. This is basically a hospital setting of how an EEG looks like. In short, what you're gonna do is you're going to, okay, first of all, everyone has different head sizes, okay? Everyone's head size is different. It could go from a child to a teenager to an adult. Some people have microcephaly, some people have macrocephaly, etc. So we need to find measures on how to put this EEG in a way where it's not different from person to person. So what they do is they take a measuring tape, they measure from the nasion, which is the nose, down to the inion, which is basically the most protruding part of your occiput. They're gonna measure it. Okay? The midpoint of this measurement, they're gonna mark it. And then they're gonna do the same thing between the preauricular area on the right and the preauricular area on the left, and measure the midpoint of that. Where the two midpoints meet, that's your vertex. Vertex meaning the highest point in your brain or in your head. Okay? Now, based off of these measurements, they're going to start putting labeling, this is the frontal, this is the occipital, these are the temporals, and this is the parietal, as you can see by the letters placed over here. Okay? And then they're going to start placing electrodes and whatnot by a 10 to 20 placement method, where they take 10% of this area, 20% of this area, whatnot, and they just put the electrodes, okay? It's not important, at least in the OSPE, okay? And then you have central areas over here, okay? بس والله يعني, that's it in this area. When we look at what you guys did in the lab, you had 3 electrodes. You had 1 electrode on your right forehead, 1 electrode on your right occiput, and then another electrode that's an earth electrode just to stabilize the environment and all that stuff on your left forehead. Okay? Ideally, as I said, because the EEG can be stimulated or affected by external environment, typically in a recording of an EEG, the room should be quiet. The room should be soundproof so you don't hear anything from outside. It should be dark because eye stimulation can also affect the EEG, and the patient should be relaxed and calm. You can imagine if the patient is constantly thinking of something, it's going to affect the EEG, as we see in a little bit, okay? Now, this is the actual important part, okay? We have EEG waves. Do you guys know any EEG waves that were mentioned to you previously? There are 5 waves that we can detect by an EEG: alpha, beta, theta, just 2 more, delta, and gamma. Exactly, inshallah. So we have alpha waves, beta waves, theta waves, delta waves, and gamma waves. Now let's go into the actual details of when you would see these waves. An alpha wave is when a person is relaxed and calm and they have their eyes closed, okay? I'm awake, but my eyes are just closed, okay? You would see the alpha waves. If you open your eyes, you would see beta waves, okay? So in the state that I'm in at the moment, if you were to put an EEG on me and I'm awake and I'm alert and if I'm quiet, you'll see beta waves, okay? It would be reduced if the person is taking sedatives or has cortical damage. Sedatives, why? Is because sedatives put you to sleep. So obviously, if you go into sleep, that's a different wave. And cortical damage is because if you have cortical damage, it's going to affect certain areas of your brain. You might not be alert, you might not be awake, you might not be able to even open your eyes, okay? If you've noticed, I've put hertz over here. These hertz are important in terms of your MCQs, okay? No, I don't think it's important for your OSPE, but it's very, very important for your MCQs. I remember the doctor, stressing on them. So do know them, okay? Now you have your theta waves. Your theta waves are seen in sleep, in your light stages of sleep, and it could be normal in awake children, but it's never found in awake adults, okay? Okay. Now we have delta waves. Delta waves are found in deep sleep, okay? D in delta, D deep in sleep, okay? And we're gonna see a couple images of how the waves look like, but it has the highest amplitude compared to the other waves, okay? Then we have gamma waves. The gamma waves are responsible for, or you can see them when the person is actually thinking of something. Like you tell them to close their eyes or something, and you give them a math equation. Them actually actively thinking and solving the math equation, you would see gamma waves. Tamam? Is this all clear? Is it clear? Okay, I'm gonna assume that it is clear. Okay. Now let's go into the actual waves and how they look like. This is a summary from my lab committee that they did. It's really, really nice and it summarizes everything that I just said, okay? However, I want to look at these waves. As you can see, let's go into the alpha waves. The alpha waves kind of look like this. They have a little bit more frequency, بس إنه this is how they look like. What I want to point out specifically is the delta waves. Actually, let's go to another. Okay, we'll get back to this later. But the delta waves, it has a very high amplitude, okay, compared to the rest of them. Tamam? This is how beta waves would look like. It's a lot more, there's a lot more frequency. Mu waves into ما عندكم, okay? There's another picture later where it shows a clear image of what you need to know. Tamam. Now, wait, before I go into the sleep, is everything clear? Okay. Now for sleep, this portion of the OSPE was not mentioned in your OSPE material module. However, I did see it in previous OSPE exams. So I'm going to mention it just to be safe, but generally you should know this from your lecture, okay? Tamam. What are the stages of sleep? Can anyone tell me what the stages of sleep are? What are the stages of sleep? N1, N2, N3, and REM, inshallah. Okay. So sleep is basically just a state of unconsciousness and it's temporary, but you can be aroused by sensory stimuli. In comparison to, for example, a coma is a temporary unconsciousness, but they cannot be aroused by sensory stimuli. Okay? So sleep is divided into 3 stages: the awake stage, awake, and then the non-REM, which is N1, N2, N3. N4 is there, but it's not really talked about. And then the REM stage. The brain goes into cycles of all 3 stages, and then the cycle itself usually lasts 90 minutes. Okay? Most of your sleep is spent in the non-REM sleep, and the rest, a small portion of it, is in the REM sleep. Okay? As you can see over here, you're awake, and then you start to go into a little drowsiness, and خلاص, you're about to go to sleep. You enter into the non-REM stage number 1. You spend some time in there, which is very light sleep. And then you go into 2, and then you go into deep sleep. And stage number 3 and 4 are deep sleeps. Okay? If a person wakes up and they're mad or they're tired, just know that they probably did not go into their non-REM stage 3 and stage 4. Okay? After they're done with stage 4, they go into REM sleep. Okay? Once they're in REM sleep, this REM sleep is where all your vivid dreams happen, and it's where the brain is most active. Okay? I think, yeah, basic, that's it. And then the person goes into multiple cycles in their sleep, usually I think around 4 to 5 cycles in their sleep. Okay? Okay, this is what I was talking about. This was taken from your slides, and it's a lot more representative of what the waves look like. Okay? This is when you're awake but your eyes are closed. You see the alpha waves? It's more frequency والامplitude it's more frequency وشوية amplitude. Okay? This is when you're awake and خلاص, you're about to go to sleep. Okay? Then you go into your stage 1 sleep, which is very light sleep. Okay? Very light sleep, as we said, is seen in shows theta waves. Okay? When you go into stage 2, again, it's like a little bit, it's deeper, but it's not too light. You see very characteristic waves of spindle and K complexes. Okay? I can guarantee you, يمكن like 80%, a question is this question. They're going to ask you this question. Okay? They're going to give you this and tell you what stage, or they're going to tell you this and tell you and ask you, point out the complex. Okay? Here, delta waves, as I said, in deep sleep, as you can see, do you see how high the amplitudes are? This is representative of delta waves. Okay? And then you have stage REM sleep, because REM literally it stands for rapid eye movement. Your brain is super active. So when it's super active, it kind of mimics beta waves. It is beta waves, and it's weird because you're supposed to be sleeping, so you're not supposed to see active waves, but it's beta waves. Okay? This is another table taken from my lab committee, and it summarizes everything. Is this clear so far? Oh, by the way, حتى في هنا bats drink blood. This is a mnemonic. B for beta, when you're awake. You still did not go to sleep. You're awake. A for alpha, when you're خلاص, you're about to go to sleep and you put your head on the pillow and you're about to sleep. Okay. T for theta, عشان light sleep. S for spindle and K complexes in your N2 stage. D for delta in deep sleep. And then B again for beta in REM sleep. Okay? Okay. Now, let's do a couple questions. Okay. This question, يعني, this question was repeated in every single batch. Okay? So just guarantee that this is gonna come in your exam. Okay? An EMG study is done in a diabetic patient. No. Calm down. Wait. No. Okay. EMG study is done in a diabetic patient. What not? Okay, whatever. The time is 4 milliseconds and distance is 2 centimeters. Okay? Calculate the conduction velocity. One thing I unfortunately missed and did not say is that distance over time, distance is in meters, with time is in ايش اسمه seconds. Okay? Meters per second. He's asking for meters per second. The units they gave you is millisecond and centimeters. You have to be super, super, super careful because the concept is so easy, but a lot of people miss it because they don't notice the units have changed. And they can trick you in the exam and give you the option that you, like, give you the option of if you divide 20 by 4. Okay? So distance over time, which is 20 over 4. How many centimeters are in a meter? 100. And how many milliseconds are in a second? 1,000. It's okay. It's okay. I literally had to relearn this when unfortunately, I had to relearn this when I was doing this. ف what happens is in you do distance over 100 because you have 100 centimeters in a meter, which is 20 over 100, and then 4 over 1,000. You're gonna get these decimals, which is gonna give you 70 meters per second. This is the answer. Okay, and they give you the same exact numbers every single exam. Okay, but still, يعني if you do get this, do solve it just in case, because there might be like a little trick in there. Okay, no, 70. Do you want me to do the math? I'm afraid it's 70. I'll check this after and then let you know. Okay. So just a reason for the latency, it would probably be like a peripheral nerve damage. Okay. تمام. A medical student recorded the EEG in a relaxed, calm, and quiet laboratory setting. While he was awake and his eyes were closed. He was then asked to open his eyes. What change would be expected in the EEG? So it would go from what to what? From alpha to beta, which is from C to B. Perfect, mashallah. Tamam. Perfect. Okay. What is the name of the area that we put the electrodes on? Which is, okay. And what's the name of the marked area over here? It's this one. This is the center of your brain or your head or the vertex. So it's called CZ, central zone. Okay. And the area that we put the electrodes on is from the nasion to the inion. Okay. Nasion to inion or inion. Okay. هذه كمان it's always repeated. Okay. تمام. Is everything clear so far? Okay. Let's get into this. 28-year-old male who presented with a 12-hour history of fever, headache, confusion, photophobia, and neck stiffness. What's your diagnosis? Meningitis. Okay. Which takes us to microlab. Okay. In microlab, we're going to talk about meningitis, and that's it. Meningitis is basically the inflammation of the meninges, and it could be due to anything: bacteria, viruses, fungi, parasites. For the sake of microlab, I'm going to talk about bacteria only. Okay. Signs and symptoms of meningitis would be fever, which is the most common thing. Obviously, if it's an infection, you're going to see fever. Headaches because of the stiffness. Photophobia, phonophobia, and neck stiffness. Okay. What we do to diagnose a meningitis case is we do obviously a bunch of physical tests, as you guys have probably done in pro. And then you also have to take a CSF sample and a blood sample. Okay. which is what we will be doing over here, which is a lumbar puncture. Again, you guys have probably done this in your pro, but at what level do we put the needle in a lumbar puncture? If you guys know. L3 to L4. Perfect. Why do we put it at L3 to L4? What's the reasoning? It's because the spinal cord has already terminated at L1 to L2. So we put the needle in an area, we know in the L1 and L2, the spinal cord terminates there exactly. But the subarachnoid space or the matters, the dura matters and the meninges still extend downwards. So we can still take a sample from below the spinal cord. Tamam? Now we take 3 samples. We have to take 3 tubes, and every tube needs to go somewhere. It's not for one specific thing. Do you guys know tube 1 goes where, tube 2 goes where, and tube 3 goes where? Like, what do we test them in? Okay, so 1 is for chemistry and immunology studies, 2 is for microbial examination, and 3 is the cell count. Okay, now if there is an actual infection, we need to take these tubes to the lab within an hour, because as you let it stay, the bacteria is going to obviously, you know, there's gonna probably be so many changes that it can give you مثلا like false positives or something later on. We need to take them down as soon as possible. Okay. Now, this table, in terms of micro, know it like your life depends on it. They will ask you so many questions over this, whether it's an MCQ or OSPE, they will ask you like there's no tomorrow. This is super important, okay? Let's go through this very quickly. A normal CSF should be clear, should have 0 to 5 lymphocytes or even nothing. It's so sterile, it doesn't even have lymphocytes or red blood cells or anything, okay? Obviously, if you gram stain it, it will be negative. The glucose and protein should be normal, normal levels. They're gonna give you the normal levels or if it's high or low in the exam. Bacterial meningitis, when you take the CSF tube itself, you're gonna see that it's turbid and it's yellow, okay, because of the pus, okay? What would you see under, the microscope and stuff when you assess for cytology is neutrophils, okay? Most of the time it's neutrophils, okay? The neutrophils will be high. Gram stain will obviously be positive. Proteins will be high because the bacteria is there and it's forming all this pus and there's so much lymphocytes, neutrophils and all that stuff. The glucose will be low. Why? Because the bacteria utilize the glucose. It needs the glucose for its energy. So you're gonna find that the glucose is low. It's being eaten up. Okay? Clear? Viral meningitis, it's going to be kind of tricky because it will look like a normal CSF, cytology or chemistry. But one thing that could lead you to think it's viral is if you see في cells, there's lymphocytes. Okay? When you see lymphocytes, it's probably viral. Okay? But you can't tell from the appearance or anything because it's usually normal. Normal looking. Okay? Now, chronic meningitis, TB, or fungal, you'll see that it's turbid. And specifically in TB, there's fibrin material that usually deposits at the bottom of your tube. You'll see lymphocytes and neutrophils, both. Okay. When it's chronic, you usually see both. You're gonna have more lymphocytes, less neutrophils, but they're both still there. Okay. When you do a gram stain, it will be negative. Okay. But if you do a gram stain, as in like acid fast stain, you might see TB. Well, fungus, أكيد it can't be gram stained. You have to do its other special tests. Okay. Protein will be really high. The glucose will be fine. They don't really need our like it might be a little bit low, but it's not going to be as low as bacterial. Okay. Is this table clear? Because it's actually super important. Okay. Now, what do you guys again, let's like reiterate on this. What would you see on macroscopy or يعني with your own eyes? What would you see in a CSF tube? You would see the color and you would assess إيش كمان. You'll basically assess like if the how turbid it is, like how the volume itself, is it thick, is it watery, is it whatnot. Yeah, basically appearance. And you're gonna use them for culture. So again, if it's clear, it could be normal CSF, it could be viral. If it's milky white or turbid, it might be bacterial. If you see blood, take him to the CT and check if he has subarachnoid hemorrhage. Okay, you should never see blood in a CSF sample. Okay, on microscopy, we will obviously use it for the cell count, and you would use it to stain in microorganisms and see what you guys have and what there is in the sample. So this is what you would see. This is a normal CSF. This is a turbid CSF. This could either be fungal or bacterial, more likely fungal though. Xanthochromic CSF is this yellow color, but it's not turbid, it's just yellow. Why? It's because when you have a subarachnoid hemorrhage and you have red blood cells in the CSF, they will be broken down into bilirubin. And this is why it gets this yellow color. Okay? So immediately, xanthochromic, think subarachnoid hemorrhage. Okay? Now, this is some pictures that I've taken from your lab committee, and they're actually very good pictures. Can you guys tell me what this sample might be? This sample could be normal or could be viral. Okay? Yes. What's this? What would this be? Bacterial. And what would this be? Not TB. Fungal بالضبط. Okay, that's perfect. Fungal, you would see opacity or turbidity, but it won't be as yellow as the bacterial. Okay, the bacterial, you know, it forms pus and all that stuff. The fungal, it's just turbidity. Okay, or opacity. Okay, now what? Okay, this, يعني, it looks normal, but if you look at the bottom here, there's these fibrin molecules. What would this be? TB, subbed, and then this, imagine it has a red color in it. Red hue. Exactly, subarachnoid hemorrhage, the xanthochromic. Okay, perfect. Okay, now let's get into the organisms. Identify this microorganism. Fast, we're about to be done. Strep-ish. Strep pneumonia, exactly. So for strep pneumonia, what you basically need to know for your OSPE is your normal POD information. They'll never ask you anything more than that, except if they give you special tests. So you need to know that it's gram-positive diplococci. It's the most common agent to cause meningitis, especially if the person has had a CSF shunt. What a CSF shunt is, if you guys remember, if a person has hydrocephalus, usually they go into surgery and do a CSF shunt because of their hydrocephalus. If a person has meningitis after the CSF shunt, strep pneumonia. Okay, they're fastidious organisms. They need CO2 for incubation, and it's optician sensitive. Optician sensitive. They can easily give you this agar and ask you what organism this is, and you need to know because of optician. Okay. They also are biosoluble. Okay, just your normal POD information. Okay. What is this organism? Neisseria meningitis. Perfect. Inshallah. So Neisseria meningitis is في Neisseria meningitis وفي Neisseria gonorrhea. There's a couple differences between them, but generally they are gram-negative diplococci intracellular organisms. You would usually see them inside the neutrophils. Okay. Again, it's one of the most common agents that cause meningitis, and there's multiple serotypes, which is A, B, C, W, and Y. Okay? How you would culture a Neisseria species is on Thayer Martin agar or chocolate agar. What's the difference between Neisseria meningitis and gonorrhea is that they ferment different types of glucose. Meningitis ferments glucose and maltose, gonorrhea ferments glucose only. There's a specific agar that they use, اسمها cysteine trypticase agar, which is this one over here. They'll put the organism, and every tube has different sugars in them. Whichever one ferments, they can tell what species it is. So over here we see there's glucose and maltose are both fermented, which is Neisseria meningitis. Okay? This map picture is taken from your lecture, and because you guys have Dr. Botta teaching you and he loves maps, just know that this is the meningitis belt. And he puts a picture of the map and asks you to know what asks you a question over it. But this is the meningitis belt where these countries have the most common meningitis or have meningitis most of the time, you know? Okay, our last organism. What's this organism? Haemophilus influenza, perfect. Now, Haemophilus influenza, we have a couple of slides on it because it kind of has a lot of information to know, but generally, gram-negative coccobacilli, one of the most common organisms to cause meningitis. And they love to stress on this, but it needs factors V and X to grow. Okay? Okay. Now, if you culture Haemophilus influenza, you usually culture it on chocolate agar. Why chocolate agar? Why not blood agar and why not chocolate agar? Why not blood, best chocolate? It's in the slide. It's cultured on chocolate agar because the RBCs are already lysed, and within the RBCs you have factors NAD and hemin. Okay, this is why usually on blood agar it won't work. Okay, and this is how its colonies looks like. Okay, now if you were to actually culture Haemophilus influenza on blood agar and actually want to see a difference, you have to culture it with Staph aureus. Okay, why? Because we know Staph aureus is it's an organism and it can lyse the red blood cells. Okay, so when you put Staph aureus on the agar and it lyses the red blood cells, it's going to give you the factor X that you need. Staph aureus already secretes factor V. So it's basically giving you both factors in one, allowing Haemophilus influenza to grow. So we can use this to do a little test called satellism test. Okay, we put a strip of Staph aureus, and around it we put Haemophilus influenza. We incubate it and then we come back. We will see that obviously the Staph aureus has grown, and then we would see Haemophilus influenza growing next to Staph aureus. It won't be growing anywhere else. It's going to grow near Staph aureus because Staph aureus is lysing all of these things for it. Okay? They can easily give you this agar and tell you to name the technique. Does this part make sense? And does it make sense to know why it would grow on blood agar in the presence of Staph? Okay. Small difference between Haemophilus influenza and Haemophilus parainfluenza is that Haemophilus influenza needs factors V and X. Parainfluenza would only need V. Okay. Now, apart from culture or apart from agar, we can always do a latex agglutination test, which is just basically testing directly for the antigen. We put the antigen on the the latex part of this. We take a scoop of the culture that we cultured to Haemophilus influenza, mix them together. If they agglutinate, that means a positive agglutination test. And type B is the most common one to cause invasive disease in Haemophilus influenza. Okay? Now let's get into questions and then you guys are free to go. Case 1, 52-year-old male presents with history of sudden onset severe headache. And it occurred when he was at his desk yesterday. Meningitis. Okay, what type of meningitis? His white blood cells are normal. His red blood cell count is raised. His glucose level is normal. Protein is normal. And he has xanthochromia. What's your diagnosis? Or what type of meningitis is this? Exactly. Subarachnoid hemorrhage. Not meningitis, but subarachnoid hemorrhage. Our next case is a 55-year-old woman has been getting more confused. She has been vomiting, suffering, lacking energy. No neck stiffness, but her CD4 count is very low. Okay? Fungal. Why did you say fungal? Exactly. Fungal usually affects the immunocompromised patients. Inshallah. Now, for our third case, someone has been coming with headache, photophobia, mild neck stiffness, and corseal symptoms. She is fully oriented and her observations are stable. White blood cells are primarily lymphocytes. Glucose is normal. Protein is like kind of normal. Viral, exactly. Why viral? Exactly. Lymphocytes, but then everything seems normal except for lymphocytes. Also corseal symptoms. Exactly. Then we have 30-year-old patient, cough, weight loss, fatigue, night sweats. She had bronchitis. Chest x-ray shows upper lobe infiltrates. And from this, you could know. Her white blood cells are high. Exactly, TB. Her white blood cells are high, low red cell count, glucose is low, protein level is high, which is TB, exactly. And then we have 28-year-old woman, presents with a 12-hour history of high fever, severe headache, confusion, photophobia, neck stiffness. White blood cells are super, super high with neutrophils. Glucose is very low, and protein is low. Bacterial. Perfect. Okay. What's this test? And what do we use it for? Like, which organism do we use it for? Latex agglutination test. What do we use? Like, which organism do we use it for? Out of the three we talked about, it's used for one organism. Exactly, H. influenza. What's this test? And which organism do we use it for? Exactly. Okay. Cysteine, trypticase, agar. What's it used for? Not H. influenza. Neisseria meningitis. Neisseria. As I said, remember when I said Neisseria meningitis would ferment glucose and maltose, when Neisseria gonorrhea would only ferment glucose. Okay? What's this test called? And what are the two organisms found here? Satellitism. Okay, what's the two organisms? What's this one in the middle and what's the one around? H. influenza and Staph aureus. Perfect. Okay. You took CSF sample of someone's fluid. Wait. You took a CSF sample and you looked under the microscope and you see these cells. What does that primarily tell you? Seems like viral, exactly. Because it's all lymphocytes. Okay. And that concludes this OSPE/mini crash course. I hope this was beneficial for everyone, and I hope it genuinely is a good review for you guys. I hope everything was clear. And please fill out the form, let us know your feedback. It's our first time teaching. And best of luck. Thank you guys so much.